Italy.
गजब बेइज्जती.
হ্যালো, যার ফলে কি হলো তো মাঝে মাঝে স্ক্যান করে আওয়াজ চলে ব্যাটারি আছে।
Sir, the screen is not visible, sir.
সব জানা ভালো, ঠিক আছে, বেশি জানা ভালো। চারশো দিবা করে, ঠিক আছে, ওরা চেঞ্জ করে খারাপ লাগে। হ্যালো, কোথায়?
I think all the participants had uploaded their PPT. We are waiting for our কখন আসছেন? এমনিতে আপনি আপনি এক কাজ করুন না, পোস্ট লাঞ্চ সেশনটায় চলে আসুন ভাই, লাঞ্চে চলে আসুন। ঠিক আছে, ঠিক আছে, ঠিক আছে। 11:30, 11:30। হুম হুম, একটু লেট চলুন। হুম হুম, ঠিক, ওকে। Good morning, all the respected delegates who are present offline and online. Welcome back to the last day of ACPICon 2023. So one of the most interesting and most awaited session of any conference is the paper presentation. And I think we will start the oral paper presentation. We are really fortunate to have with us Professor SP Dhaneria sir. We welcome you, sir. So along with Professor SP Dhaneria sir, we also have Professor C. Prabhakar Reddy sir from Nizam Institute. I welcome you, sir, also to become the judge. And may I request Professor C. Prabhakar Reddy sir to say a couple of words, because this prize is dedicated by sir and his team. So may I request sir to kindly introduce the prize and say a couple of words to our delegates. Please, sir.
Good morning, everybody. So, as clinical pharmacologists, I think most of us from South India, we started our life with one or two of great people. And I think they're known around the country. The person who started this for us, specifically for us, and we are proud to say that we are students of those great people. So in their honor, last year we had announced couple of prizes. One, I think everyone would have heard of Dr. Naidu, a great person, a great teacher. Now, sir is happily staying at home, having a good retired life, but sir is more depressed because he has stopped teaching people. His passion was teaching, and now there is no one to teach. So in this condition, sir is little bit depressed. So in his honor, we like to we have announced best oral presentation, which will carry a prize. I don't remember, I think 10,000. Last year we have announced, and it was given also. Then this, and the second one which we have was another great person was that Shobha. Shobha U Datta, a great person. She will not speak out, she will not come out. But when we go to her, she is not going to leave us until we are satisfied with what doubts we have. And personally also, she was very good. Like, she used to help us so much for students. So in these two people's name, we have one oral presentation prize and one paper presentation prize, which unfortunately, I think we missed. Is it Dilika? Fortunately, what happened is that this year, last year, I personally supported it. So and then 15,000, then somebody asked, why can't we have a lump sum amount as a fixed amount so that every year it can be taken care of. So fortunately for me, because this year I'm not going to put from my pocket, is that one society, like Society for Pharmaceutical Medicine and Research, has come forward to support the prize. It is headed by Dr. Sinha, Subhadeep Singh. And I am a member secretary of that association. And there are various other people from some parts of the country who are part of the association. And they have come forward to support this prize today. So we thank them. And this is our intention of having these prizes to encourage mostly students. So next time we'll have for students only prizes, because we want them to come out. And next time we'll keep a condition, minimum 15 oral and 15. If they don't come with this many, we'll say there is no prize. So we want all young minds. Now almost we have around 30 to 40 seats in the country. Okay, all of them have to come forward to compete. A set should come where we have so many prize applications for presentation, we should be able to reject them based on their these things. So we wish every student to come forward and participate. Next year, it's in Mumbai mostly. So if more people come, we'll ask the sponsor to increase the prize money also. And we'll try to ask them, if you are so much good studies, if you have, we'll try to ask them for funding. So if you, this is an encouragement for you. It's very small amount, 10,000, 5,000. It's very small amount if we take it personally. But this is a small encouragement. You start doing your work more. We'll try to increase the price. We'll try to come out with more like a sponsorship of small studies. So you have to encourage us so that you will benefit and your students are going to benefit. So I'd like to take this opportunity for thanking the organizers who have done a great work. I think for the last 1 month, I think our person he'll not be any sleep or full tension, because we had the same feeling when we were last year conducting ISPR. So I take this opportunity to congratulate them for organizing this. This is a small one, because we are now just growing up. We're just kids. This is a small one. He's lucky to escape because he has started conducting second time. So let us imagine 5th conference or 6th conference at the end of 4 or 5 years, you give organizers big headache. Okay, thank you. And I wish all the best to the future students and the presenters who are going to present. Thank you.
So may I invite the first presenter, Dr. Kumar Vel. Dr. Kumar Vel J.
It's not working. So,
Dr. Kumar Vel J. Is not this mic?
So very good morning to everyone. The research work as a part of my thesis, a small part, I just want to present in this perfect platform. So the topic is development and validation of an HPLC method, like LCMS-MS method for quantification of azacitidine in human plasma and application in pharmacogenetic study of acute myeloid leukemia patients. So coming to the background, azacitidine is basically a DNA hypomethylating agent, which is already approved for the maintenance of remission in AML patients, but being tried for induction of remission in AML patients, those who are not the candidate for standard 7+3 regimen, and also not the candidate for hematopoietic stem cell transplantation. So because of the instability of this particular azacitidine, so it is very difficult to isolate this from the plasma and also from the quantify in the plasma. So aim of the study is to develop and validate an LCMS-MS method for the determination of azacitidine in human plasma and to apply in a pharmacogenetic study in AML patients, that is acute myeloid leukemia patients. Coming to the material methods, so we need chemical reagents, instrumentations, LC conditions, MS conditions, and preparation and mobile phase and choosing of column and the preparation of stock solutions and working standards. Coming to the chemical reagents, azacitidine, that is reference standard, purchased from Toronto Research Chemicals, and IS we have used is 5-methyl-2-deoxycytidine, then tetrahydrouridine, which is a stabilizer. Like actually azacitidine will be getting degraded easily. So to avoid the degradation, we should use the inhibitor of the cysteine deaminase, so it will prevent the degradation of the azacitidine. And also other chemicals like water, methanol, acetonitrile, these all LCMS grade we have used. Coming to the LC conditions, so we have used C18 column, that is column is the heart of LCMS, like LC. Then mobile phase is, so these A mobile phase and B, this is we have optimized by using trial and error method, like by different permutation and combinations. So this is the mobile phase A and B. Coming to the LC conditions, that is we have used gradient method, not the isogradient one. So this is the flow rate, like 0.6 ml per minute, and this is the time run time, that is 7 minutes. So this is the concentration of this mobile phase A and mobile phase B. Coming to the chromatography conditions, so overall temperature is 50 degrees Celsius, flow rate is 0.6 ml per minute, runtime is 7 minutes, autosampler temperature is 5 degrees Celsius, then elution technique is gradient method. Coming to the MS conditions, we have used SciX mass spectrometry, that is triple quadruple 3500. So the mass spectrometry was operated by using positive electron spray ionization mode, so which was controlled by a software called Analyze software. So this is the MS conditions. So this is the curtain gas which is used, and this is the spray, like ionization spray, which is 5500 volt. Then this is the temperature, and this is the gas spray ion 1 and 2. This is the MRM, that is multiple reaction monitoring, like for azacitidine. This is in Q1 it is 245, for IS that is 5-methyl-deoxycytidine it is 242. So these are dual time. This is the potentials, the different potentials, which is basically it is in the MS conditions. So this is the analysis software I was telling, which was used for this LCMS reporting. So this is the chromatogram I got while doing this LCMS. So basically in x-axis, it is the runtime. In y-axis, it is intensity. So you can see the peak over here. So at 2.60 minutes, I got the drug that is unlit of my interest. That is 5 associated. I got in 2.60. So THU, that is tetrahydrouridine, which is I used to stabilize this associated prevent the degradation. That is I got in 2.87, and IS internal standard is very important. I got in 2.95. So it is highlighted here. 2.9695 is the IS. So this is the results I got from the LCMS. You can see this is the blank IS and calibration standards. So this is the analyte concentration, known concentration which is used, and this is the area I got. So from here you can see that I got accuracy of 80 to 110%, 120%. This is the IS area. So coming to this particular graph, this is a linear regression curve. I got R of 0.99. Calibration curve based on this analyte concentration known and area ratio, that is analyte area and IS area. So this is the calibration curve I got. The R squared is 0.999. So this is basically done for QC, for accuracy and precision. QC controls. So low QC, middle QC, and high QC are done. So we have got a good accuracy and precision. So matrix effect also I did as a part of LCMS for IQS and also for the plasma extraction in different samples like 6 aliquots we have done. So this is the mean value. This is the mean value I got, and this is the coefficient of variation I got like 7.7. This is for LLOQ. This is for ULOQ. That is upper limit of quantification. So based on this study, like research work, so I hope the method is validated and it is simple, accurate, precise, and also we have followed ICH FDA guidelines for validate this method, and we are also able to get the azacitidine and IS and tetrahydroidine were eluted in different retention times, and 2.6 minutes is the retention time we got. So coming to the discussion, there are 2 studies only available. They have already done this work. So they have used solid phase extraction method. I have not used, so I made simple little easier. Coming to the conclusion, so it is possible to conclude that this method can be used for my study, for the pharmacokinetic study in AML patients for quantification of azacitidine. This is one of the patient sample I have got the peak. So these are my references. So gratitude to ma'am. She is my mentor, and he is the LCMS analyst. So he helped me a lot during the method development and validation. Thank you so much for giving me this opportunity, sir.
Okay, it was a nice presentation. I think during development, I think you did development also.
Yes, sir.
Development and validation.
Yes, sir.
And what are the various parameters you looked on which are going to influence the level of outcome?
Like what are the parameters? Matrix effect, sir. Then stability. So we have checked for stability also, like different
Stability. What are the different parameters you checked?
Stability means we have checked for 45-day stability and 60-day stability in the plasma in -80 degrees Celsius. Sir.
-80.
Yes, sir.
Just -80 or some range?
The sample was frozen at -80, and also -80 was there, also -20 also.
So when you say that you have followed ICH FDA guidelines.
Yes, sir.
There, when we go and see the method development and validation,
Yes, sir.
you have so many variables that
Yes,
are
sir.
going to.
So many parameters are there, sir.
Okay.
Yes, sir.
Okay. So the work which you have done is good.
Yes, sir.
So now I think I want to ask a general question. You had done a great work. What you are going to do with it?
Sir, so basically we can able to quantify the azacitidine level, sir. So ongoing thesis is there, my research work.
Okay.
So I can apply this LCMS method over there.
Oh,
So
so
for
it's a part
AML
of your
pediatrics-
research.
Yes, sir.
It's part of your thesis.
Yes, sir. It's the PKPD model I'm doing. So I want to apply this method for quantification of the levels
That's
there.
good. Is it going to have some value to the patient who comes to your institute?
Definitely, sir. Actually, it will help in not as a routine clinical service. So for developing some nomograms, it will be helpful. So once I quantify these levels, I can put these data into population pharmacokinetic modeling. So I can develop some nomograms. So it will help for ultimately for patient care help, but not as a routine clinical service. We cannot use this because as per se, this accelerating is not required as a routine clinical service TDM.
Okay. So this is another thing which I want to say in the first thing. So whatever we want to do, let us, this is not, let us do it so that at the end of what we did, you just have a question when you start doing, is it going to help the patient? So once you do something and your colleagues or somebody starts using in your institute, you get credibility.
Yes, sir.
And they start asking Kumar, well, where he is, where he is. Even if you're out of PGI, they'll call you and ask, what should we do?
Yes, sir.
So once you do something to patient care, we need not look back and we are going to boom ourselves. Until that,
Yes, sir.
okay. So next time for this awards, we'll be asking each and everyone, what is the relation of your work to patient?
Yes, sir.
Okay. Best of luck.
Thank you, sir.
Any question?
Any questions? So next, if no one asks questions, we'll give him minus marks. Hmm?
Please ask questions.
Yes. And he should,
I ready to answer.
Yeah.
Like I try to answer.
let us make it a, like,
Some
let us make it a
discussion.
class. Okay, I think we have Manjunath waiting to ask something. Yeah, Manjunath, you can ask. Manjunath.
Please, sir, go ahead, sir.
I think Sinha sir has come online. I think he typed that, can I ask question and left. Okay,
Thank you, sir.
so when he asks question, we'll ask the
I
same
try to
question.
answer this.
You have to answer.
Yes, sir. Thank you, sir.
Okay, thank you.
Dr. Brototi Sannal.
You can answer.
Good morning. So my study title is a single center retrospective comparative clinical study between dapagliflozin and empagliflozin in patients of type 2 diabetes mellitus already on metformin monotherapy. So both dapagliflozin and empagliflozin come under a relatively recent class of oral antidiabetic medications. They block the sodium glucose cotransporter 2 protein located in the proximal renal tubule, thus inhibiting a major part of glucose reuptake in the body. Besides reducing the plasma glucose level, they also decrease the blood pressure and body weight, which attributes to long-term favorable cardiovascular effects. However, the chances of lower urinary tract infections, both by mycotic and bacterial, are increased due to glycosivia caused by these agents. So objectives of my study were to compare the clinical effectiveness of dapagliflozin and empagliflozin in terms of reduction in glycated hemoglobin, fasting blood sugar, postprandial blood sugar, and body weight from baseline, and to compare the safety of dapagliflozin and empagliflozin in terms of incidence of UTI. So materials and methods, study type and design, it was a retrospective observational study. Study area was General Medicine OPD and Pharmacology Department of College of Medicine and Shagodatta Hospital. Duration of study was 4 months from 1st March to 30th June 2023. So inclusion criteria, patients of either sex aged between 18 to 71 years who were either on dapagliflozin 5 or 10 mg once daily or empagliflozin 10 or 25 mg once daily for at least 6 months in addition to metformin. So sample size was total 47, 26 in DAPA group and 21 in EMPA group. Convenient sampling method was followed. So it was a prescription-based retrospective study. Prescription of 47 type 2 diabetes patients who were either on dapagliflozin or empagliflozin for at least 6 months in addition to metformin were evaluated. So the current biochemical details of FBS, PPBS, HbA1c data of all the participants were statistically compared to the respective values 6 months earlier, as stated in the prescription. So changes in body weight and history of urinary symptoms during the same period were also analyzed. So now comes the results. So the baseline FBS, PPBS, and HbA1c values between the groups did not exhibit statistical difference. However, the data after 6 months showed that patient among the EMPA group had numerically better but statistically insignificant glycemic profile in terms of number one, HbA1c. So I have shown here a bar diagram to compare the final HbA1c values after 6 months in both the groups, and p-value is 0.4. So next is the FBS values after 6 months. So in both the groups, DAPA group and EMPA group, another bar chart has been shown. P here is equal to 0.66. So again, non-significant difference. Next is PPBS. So here again, P is equal to 0.9 and another bar diagram to show the final PPBS values after 6 months in both the groups. And body weight wise, this is reverse. That is, in here DAPA group has appeared better. That is, DAPA group has shown better weight reduction in my study. So P is equal to 0.524 and a bar diagram to show that. And here is a table showing the 4 parameters and the respective values in both the groups after 6 months, and also the respective P values have been shown. All are non-significant. And finally, UTI. So 3 cases where UTI were reported in each group. So in DAPA group, it was 3.84%, and in EMPA group, it was 4.34%. That is, in EMPA group, incidence was slightly higher. P is equal to 0.462. That is again non-significant. So next comes discussion. So EMPA group showed better reduction in glycemic profile in our study, which was similar to a clinical trial conducted by Hussain M. et al. But our study showed comparatively lesser incidences of UTI and better body weight reduction with dapagliflozin, which was contradictory to the referred study. Our study showed that EMPA had numerically better but statistically insignificant glycemic profile after 6 months. But in a similar study conducted by Ku Ij et al., the difference between the 2 groups were found to be statistically significant. So strength of my study was that it was a real-world study, and limitations were, it was a single center study, sample size was small, convenient method of sampling was followed, and it was a retrospective record-based study. And conclusion is that both the agents are comparable in efficacy and safety in type 2 diabetes patients for at least 6 months along with metformin, and symptomatic UTI appear to be the commonest side effect. However, they are self-limiting and they usually respond to the common antibiotic therapy. So these are my references. Thank you.
Thank you very much for good presentation. You mentioned that dapagliflozin, in some aspect, it's better.
Yes.
So as far as weight reduction is concerned,
Yes.
what can be the reason for that?
Reason, I think that may be due to chance also, because I have taken a small sample size.
Mm.
So when we take a small sample size, always it can't be generalized to the population, the results. So I think for that also it can come that better weight reduction.
So in your study, what is your comment on clinical significance versus statistical significance?
Clinical significance, I think both the agents are in a clinical setting. I think both the agents are very much efficacious. And in various other studies, I have seen past studies, I have seen that AMPA is better efficacious. But here, I think GAPA has come better. So I think both the agents in clinical setting, both the agents can be given with almost equal efficacy.
And you have looked for adverse effect only
Yes.
urinary tract infection.
Yes.
Have you looked for any other problem with
Uh,
this SGLT2 inhibitor?
No, there are other side effects also, like there is diabetic ketoacidosis and all, euglycemic diabetic ketoacidosis.
Glycemic diabetes.
Yes, but as their time was short for the study, actually, I
Because
did
it was a retrospective. study.
retrospective only
So
record
nothing
based
was there in record.
record. So I only asked about the urinary symptoms.
Hmm.
I also didn't check for that microscopic results of UTI, which I should have.
No.
I only asked for the symptoms and that only I did.
Any difference in bone density?
Bone density, I didn't ask for it. It happens sometimes.
There was not in any record.
Record,
Because
no.
you went to record.
Record.
It's a record based study.
Yes, no, there was nothing as like that.
Okay. The topic is open for discussion, please. Distinguished delegates are, sure, please go ahead.
With permission from the judges, I am asking you, you had shown the glycemic efficacy, though statistically not significant, in favor of empagliflozin.
Yes, it was only numerically.
So what are the other drugs? You have not shown anything in the baseline. What are the drugs patient was consuming? And
Yeah.
during the period, what are the drugs patient was consuming?
Yes, I just said that along with metformin, they were given metformin plus.
Only metformin, no other anti-diabetic agents were used?
Only metformin plus this SGLT2 inhibitor.
Only that?
Yes.
And what about the duration of diabetes
Duration of diabetes, actually,
in the both group?
I have not seen actually a duration exactly. I have not seen. I have taken such patients whom it was not controlled by metformin monotherapy. So another agent was added, SGLT2 inhibitor, and at least 6 months that SGLT2 inhibitor was given.
So apart from that, SGLT2 inhibitors, patients were not consuming any other group of drugs. So in the baseline, is there any possibility if the duration of diabetes is not matching? So there is a possibility of confounding variable.
Yes, that is possible. I
So you
didn't
had
see
not
that.
taken that.
No.
And what is there any difference between retrospective study and record-based study?
Retrospective study, record-based study. Yes, retrospective study can be taken from the means if history is taken from the patients about their means history diseases.
What actually you had done?
I had that from the prescription, so it's a retrospective record-based study from the prescription. Yeah, no, about the urinary symptoms, I asked the patient, so it is a retrospective study.
In one slide, you had shown it is a retrospective, again, record-based study.
Yes, that will be retrospective actually, not record-based.
And what about the real sample size? Actually, if you want to see the clinically effective differences, so what should be the actual sample size for this particular study?
That I have not calculated, that I should have calculated actually. Sample size would have been much greater. Actually, I don't know the exact.
No. I had a question. Can I ask? To the speaker, please. Yeah, I'm online. I'm Dr. Sinha.
Yes, sir, you can ask, sir.
Yes, ask.
So first and foremost, good effort. There are a few pointers. One is that You mentioned that you had done from March, from when to when? Can you tell the period?
March to June.
March 2023 to June 2023. And when was the, you took an observation, you were going, so you did the observations now or you did the observations during that period?
I did that during that period only from the
So it
prescription.
cannot be called a retrospective study. It is a prospective observational study. Okay, so during that period, if you are doing as the prescriptions are coming, it cannot be called retrospective study.
Actually, I said retrospective because I saw from 6 months ago what were the initial values before.
Maybe it's more of a hybrid because you are also observing some of the current prescriptions. Is that assumption right?
Yes.
So don't call it either retrospective or prospective. It's an observational study. And secondly, when you say in observational studies, since these are not controlled, not interventional, efficacy is a very strong term. The word that should be used is effectiveness rather than efficacy. Efficacy is used only in the, used in primarily in the controlled trials where there is, the intervention. So third thing is, you cannot draw much conclusions unless there is a data on the compliance of the drugs during this period. So drawing, because if the patients have missed certain drugs, some dosages during the period of observation, then they are likely to change the outcome of your, especially, and therefore efficacy is not the right word. You should have done only a safety study, would have been much better, because primarily observational studies are meant to detect safety as a primary endpoint. And last but not the least, when you did the study, did you take any regulatory permissions, ethics committee permissions, CTRI registrations?
CTRI, no, I have not taken. For ethical clearance, I have applied, but I have not yet got. Actually,
And the study is over.
Yes, sir.
And the study is over.
Yes, study. Actually, my thesis topic is on dapagliflozin and vildagliptin.
Right.
So during that, I already collected data on dapagliflozin. I am collecting. So during that time, I also collected some data on EMPA and I did the study, actually.
Now, the point is that even for your thesis, for whether MD or DM thesis, you are supposed to take ethical committee permissions from the institutional ethics committee, research ethics committees.
Yes, for thesis I have, but for this empagliflozin, I don't. I only have for DEPA and VILDA. The other I have applied, but not got yet.
Okay. So ideally, you please ensure that any clinical study, whether observational, you should take for your own protection, and there are legal implications. Please do take ethical committee permissions. It is the best way to best practice rather than not always necessary. And more ideal is to have a CTI registration. If you're going to present this, publish this, if you're going to publish this, they will ask for the CTI registration.
For thesis,
Right.
I have CTRI.
So, because the clinical trial registry numbers they ask during during the publication. So again, these are some of the pointers, not to undermine anything that you've done. Good job, but please ensure that we have an understanding of the whole spectrum of where the study is fitting in, what are the regulatory implications. Yeah, and then the design of the study, those are very important if you need to make it more robust to present and publish. Thank you so much.
Thank you, sir.
Thanks for your work.
I have a small question. Yeah, what kind of bias can come in these kind of studies? The one you have performed?
Bias, confounding bias, that confounding factors for how much time there is diabetes. I have not taken that history.
Okay.
And compliance, patient compliance. So that I have also not taken, that they have, whether they have regularly consumed the drug or not. And
Anything more specific which is particularly applicable for these kind of studies? Where do you see,
bias can happen about
recall.
urinary symptoms. from the
Yes. And
patients.
is there any structured format of prescription in your institute which has all the data of this HbA1c, fasting glucose, or it is randomly written by the
Randomly
physician?
written, not anything.
So that itself will, most of the times, most of the data is missed. Only the important ones are highlighted, right?
Yes,
And how have you analyzed the data? You are saying statistical significance between the two groups.
yes.
What statistics have you used?
I have done by unpaired t-test by Excel.
Okay, you have done unpaired t-test. Okay, thank you.
Thank you.
I think ma'am has.
Thank you. Thank you. Is there any more question from the chat box? You can just check. Ma'am, Usha madam, you have any question, madam? You have raised hand, madam. Okay, so first of all, we are really thankful to Dr. Shubhadeep Sinha sir because of his initiative. Society of Pharmaceutical Medicine and Research had participated in this conference to provide this prize money. We are really thankful to sir. And also, I want to congratulate this participant to be truthful that you had not taken the permission from the ethics committee, but I am at the same time, I am very sorry to say from the organizer side, any study without ethics committee permission, we cannot allow to be contested. So that is a very serious issue. For future things, we all should remember that without ethics committee permission, we cannot do any study. So even if it is a retrospective study, even record-based observational study, you should have a ethics committee permission. The ethics committee may think you no need to have a full board review. They can expedite the review, but you should have a proper ethics committee permission. So again, I am thankful to you to become truthful, but I think the judges will be agree. You have to remember that. So now may I request the next participant, Dr. Poulomi Ghosh, please.
Every single invention in medical science was done for the benefits of the mankind. But is it really always limited to its beneficiary effects? Good morning, everyone. I, Dr. Poulomi Ghosh, second year PGT, Department of Pharmacology in Arjikor Medical College and Hospital, am going to present my original research article, that is Knowledge, Attitude and Practice Study on Prescribing Fixed Dose Combinations among Practicing Physicians in a Tertiary Care Hospital in Eastern India. Fixed dose combinations or FDC have been created to have a positive impact in the mankind, but its improper and injudicious uses also have great risk factors to the people. Aims and objectives of our study were to evaluate knowledge regarding FDC and National List of Essential Medicine, and also to assess attitude and practice of prescribing FDCs among practicing physicians. Ours was a cross-sectional questionnaire-based observational study and was done among practicing physicians of various departmentals, OPDs and IPDs, and it was done from November 2022 to May 2023. Results were analyzed in SPSS version 28 and then documented. A sample size was calculated by this displayed formula, and we have taken a convenient sample size as 152. A pre-validated questionnaire was taken as a study tool. Coming to the result, according to these two pie charts, 41.4% of study participants were of younger age group, that is in between 30 to 40 years of age group, and 54.6% of them were junior residents. Next pie chart shows the distribution of departments among study participants. Most common source of knowledge in our study were textbooks. This 3D column chart shows that 46.7% of physicians realizes the challenge to identify a FDC component which can cause adverse drug reactions. 56% of them were aware of the role of the FDC in controlling antimicrobial resistance. But only 9.2, just 9.2% were aware of the enlisted medications and FDCs in current national list of essential medicines. This component bar diagram shows a largely positive attitudes regarding FDCs among study participants. Majority of them preferred to prescribe FDC instead of individual drug to increase patients' compliance. And also, most of them admitted the necessity to know national list of essential medicine. Coming to the practice, we can see that 40.1% and 34.9% of the physicians always write generic names of FDC with mentioning proper dosages in the prescription. 45.4% of them always do counseling before prescribing FDCs, and 42.1% and 33.6% of the physicians always prescribe FDCs from current national list of essential medicine after checking rationality of them. Most commonly prescribed FDC in our study were Montelukast with levocetirizine, followed by co-amoxiclav, which happened to be mostly prescribed from medicine and chest medicine departments. Coming to the discussion, the result of this study showed that most of the study participants are of younger age group like previous studies. Like in other surveys, a higher percentage of doctors concurred that a prescription is required to purchase a FDC from the pharmacy. 53% of doctors educated their patients on the benefits and drawbacks of FDC in a previous study, contrasted to our study, 45.4% of doctors always do the same. Like other study, ours indicated that inappropriate FDC prescriptions can raise the chances of adverse drug reactions. Textbooks were the most prevalent source of knowledge for FDC in contrast to prior study, where only 42% of information came from textbooks. 58% of respondents lacked awareness about banned FDC. In our study, 43% were unable to name a single current banned FDC in India. Coming to the conclusion, a knowledge gap is persisting regarding disadvantages of FDC and rationality of commonly prescribed FDC. There is lack of awareness about the current banned and enlisted FDCs of current NLEM. This study demonstrated that despite a generally positive view regarding prescriptions, FDC practices have certain gaps. So we recommend that we pharmacologists can organize awareness programs regarding enlisted generic names of medicines in current NLEM and FDCs. More number of articles should be published in different journals. Daily updates on the status of banned FDCs should be there. And educational improvisation in different levels of postgraduate and undergraduate training are of utmost necessity. Thank you.
Thank you, Dr. Pandumi, for presentation.
Yes, sir.
You mentioned about National List of Essential Medicine
Yes, sir.
2022. So how many FDCs are enlisted in this list?
Sir, in current NLEM, 22 fixed dose combination drugs has been enlisted.
So from your list, most commonly prescribed, how many are there in that list? Because you have mentioned about 4 or 5 FDCs,
Yes, sir.
which are commonly.
Common-
I think first is there.
Yes, co-amoxiclav.
What about levocetirizine and
No, sir.
Montelukast?
Montelukast and levocetirizine is not enlisted in the current.
Any other which is not enlisted?
Sir, pantoprazole with domperidone is also not enlisted.
Okay.
And aspirin with atorvastatin is also not enlisted.
Mhm. Now we have the problem with this, not only the ADR, they are bit costly medicines. FDCs are,
Yeah,
their cost
very
is
costly,
more.
yes.
And also this ofloxacin does not,
Is not also.
pantoprazole, domperidone.
Yes, sir.
I think out of these, Amoxiclav was there, amoxicillin,
Yes, sir.
clavulanic
Amoxicillin,
acid.
clavulanic acid and antibiotic cotrimoxazole is also included.
Cotrimoxazole, but it's not mentioned here.
No, sir.
The problem with us is that we have the list of FDCs which are banned,
Yes, sir.
but still they are available in market and they are prescribed. That is the main problem. Means if we have banned the FDC, then the regulatory authorities should see to it these are not
Not
Uh,
been practiced, not been prescribed.
Which they should not be available in the market.
Yes, sir.
Their manufacturing should be stopped
Yes.
because that is the problem. We have also the WHO essential list.
Yes.
It has 501 medicines are there and the FDCs are 51 there.
Yes.
FDCs are 51, but we have out of 384, 25 FDCs are there. So very few FDCs have scientific justification for combining ingredients.
Yes.
Okay. So what do you recommend then?
Yes, sir.
What is the recommendation from your study? How to make the people aware about
Sir, we
not
have to
using the
organize-
irrational
Yes.
FDCs?
We have to organize awareness program by arranging CMEs. We can make everyone aware of that. Daily updates of FDCs should be there and publications of more journals on FDCs and national list of essential medicine should be there. And educational improvisation in undergraduate and postgraduate training should be there.
So what is the irrationality behind this FDC that is to be stressed?
Sir,
Okay.
yes, sir. Irrationality of the FDCs. Rationality of the FDCs should be, FDCs are rational when they have different mechanisms of actions.
We have a list of
Yes.
rational FDCs where there is a greater accuracy or sometimes we are reducing the adverse effect for better compliance. For anti-TB drug, we have the better compliance. We have well.
Antiretroviral drugs we also.
Oh, yeah, definitely. Now, topic is open for discussion. Questions from delegates, please.
Hello.
Please, sir, go
Yeah.
ahead.
Yeah. Thank you for the presentation, and I think it's a good effort to try and rationalize, at least to think about that question. In the Indian scenario, yes, there are. In fact, one of the FDCs you mentioned, Montelukast levocetirizine. At one point of time, it was deemed irrational, and it took several years to get its approval. The point is there is no white and black in FDCs. Even if the multinational which are approved FDCs globally, many of them are pharmacologically supposedly irrational. Now the question is, for FDCs, there are a few things you need to look at. First is that whether in terms of in the market, whether there are two levels of approvals. One is the CDSU approval, one is the state approvals. So many of these FDCs which are are approved by the CDSU, but there are many more FDCs which are approved only by the state of drug controllers for manufacturing purposes only. The state drug controllers only give manufacturing approvals, but then they get marketed as well and branded. So the education has to be on to the prescribers and to make them understand this point as well. Besides it's not. I mean, whatever we learn in pharmacology is okay. This is rational does not always apply. There's also medical need. There are certain conditions in the CDSO guideline Schedule Y, how the FDCs, what are the points that allow you to make an FDC. So there are many other things. Most of these FDCs, and I would dare say all the FDCs that are not approved in US, Europe, and Japan, the ICH countries, have never undergone any drug interaction testing. Now, first thing that we have to also look at the safety aspects of FDCs, which is also a rational aspect. So these are all based on theoretical combinations, and secondly on marketing co-prescriptions, what is called the co-prescriptions. And based on that, either there is another term called co-packaging, or instead of that, besides co-packaging, they make a FDCs. And FDCs also have certain technologies. For example, there's something called where two drugs are just packed together with an inert layer between them, so that they don't interact pharmaceutically. So you will also to look at pharmaceutical interactions. So there are many aspects to FDCs which is not straight black and white, which we need to, nothing to do with your uh, presentations. Your presentations is a good effort study, but look, when you study this, look more closely on how FDCs get approved, how FDCs get why FDCs get prescribed, what is co-packaging, co-prescription, and then the FDCs which are approved internationally may not always be so-called rational. All these aspects need to be understood. Thank you.
Hello.
Hello.
Hello. Can I ask a question? I'm Dr. Pingali online.
Yes.
Hello. Actually, your presentation was good. Good attempt, but one clarification I have collected the data regarding the communication of the patients about the FDCs, whether the physician has communicated or not regarding that. And you have said that there was a substantial improvement in your, in your study in comparison to earlier records. But my question is whether whom did you contact, that is communicate, that is where from you get that information, who are the responders, physicians or the patient?
No, sir. These are practicing physicians, mostly from junior residents, senior residents, and faculties of our hospital, that is ACPICon Medical College and Hospital.
So there is the inherent bias here. So it's better if the study would be designed in such a way that the prescriptions, when after delivering prescriptions, you are communicating with the patients with their prescriptions in hand, and interview them whether they have been communicated regarding this details about the disease and these things. Otherwise, I think there is a bit of bias here as you are interrogating the treating physicians. Okay, so okay, anyway, that's the nice idea. There is one question Sunak has asked. What factors make them prescribe the FDC? Did you study them?
Sir, FDC is mainly prescribed for patient compliance. That is when many more drugs are giving having been given to the patient. Then if we prescribe an FDC which is rational, then it can be a costly. It can cost benefit ratio will be there, and it will increase patient compliance. Dosages can be if dosages are appropriate and the time schedule and this proper mechanism of actions, there are different mechanism of actions, and equally pharmacokinetic criteria are there in the FDC, then we can rationally prescribe an FDC and help the patients to improve compliance, because most of the cases in this country, if many FDCs if many medications are single medications are being used, then patient almost forget to take every medicine. So if we prescribe a FDC, then it will be easier for them.
Okay, so can I ask a question now, please?
Yeah, you can
Yes.
Yeah, so like you're saying, like for the compliance, like they might have given the prescriptions, right? So whether these prescriptions they have given and the patients have purchased them from the pharmacy, your pharmacy?
Yes, sir. As I have done this in hospital, Arjikar Hospital, most of these patients, the medications which are enlisted in the national list of essential medicines, which are available in our pharmacy, they got it from there. But if these Montelukast with levocetirizine and pantoprazole with domperidone combinations are not available in our pharmacy, so they have to purchase it from different pharmacy.
Okay, so coming to initial stage, like how, I mean, I might have missed it. So how did you collect the data?
I just have a pre-validated questionnaire and asked the practicing physicians about this questionnaire, and then I collected the data and did the analysis.
So did you give the questionnaire to the consultants or did you ask the consultants?
No, I have given the questionnaires and to some practicing physicians, I have to give them. I give them the questionnaire, and in some cases, I have asked them.
Great. So can you project that questionnaire once, please? And next thing, like you gave a sample size derivation formula. And again, like you said, like you have taken a convenient sample. So what is the difference between these two?
Sir, as no other study has been no other study has been done in this in this topic in our Eastern India. So I have used this sample size calculation, and after and then we have taken this convenient sample size as 152 to collect the data. Convenient sample size as how many practicing physicians I can approach, and then I have taken the data.
So either of these things you should tell, na? Either you have taken a convenient sample or the derived sample. If you have taken a derived sample, there should be some like reason for taking that sample, the parameter. So if you say n, you should tell like what is n. If you tell delta, what is the delta? So those things you should tell. If you tell that you have derived the sample size,
Yes,
right?
sir. Actually, I want to do this study in a different region also. So that is why the sample size I have taken, and then I will compare these both two data. I will compare.
Okay. So, I mean, is this study, I mean, everybody was asking previously also whether this was ethics committee cleared.
Pardon, sir?
Yeah. Is this study also ethics committee cleared?
I have got ethics committee clearance. Institutional ethics committee clearance I have got.
Okay. Okay.
This is
So,
the of my.
okay. Okay.
So same thing, I would urge you to register in the CTRI immediately if you have not completed the study, so that when you publish, it will become even better in terms of its quality.
Yes, sir.
So, this is regarding the attitude. So, what do you mean by it is validated? Yeah. You said like it's a validated questionnaire, na?
Yes,
so,
sir.
What is the meaning of it?
For validation, you are asking, sir?
Yeah.
So, sir, I have first done a thorough review of literature for this FDC, and then collected the questionnaire. And after that, we have I have given those questionnaire with my mentor and guide to other faculties of different departments in our hospital, and they have they have told about, they have given the scoring like 1, 2, 3, 4, like this scoring, that is Likert scale scoring. After that, after getting the Likert scale scoring, where 3 to 4, that is 80% of the questionnaire is valid, then I have put those questionnaire in my questionnaire. Like this, I validated.
Okay. So, you said like you want to increase the awareness of the FDCs, right?
Yes, sir.
So, how do you plan to increase the awareness?
Sir, I want to organize, we pharmacologists can organize awareness program by doing CMEs or seminars in various places like in our country, and we can do publications of more journals or articles should be there, and there should be daily status updates on the banned FDC, and educational improvisation is also utmost necessity for postgraduate and undergraduate training.
Okay, good. Fine. So, next step, what will be your next step?
Sir, my next step is to aware the practicing physicians for this, and I want to publish this as a journal or article, so that many more can be aware of this fact.
Okay, so when you were taking the questionnaire from the consultants, so did you take them as a group or like an individual in a single room? Like how did you go ahead?
I went to the departments and given the questionnaire to gave the questionnaire to them. Like in medicine department, I went and there are junior residents, and I gave them the questionnaire, and when some were busy, I asked them the question, the answer, and like this I have collected the data.
Okay, so you did not take like a group of people, right?
Group of yes, I have depicted the pie chart that there are junior residents, senior residents,
No,
faculty.
not like that. So were there any like 2 or 3 participants at a single point of time, or in how much time did they complete the questionnaire?
Like 15 to 20 minutes, I guess. I have not seen.
Okay, no. See, because all this information will be available in the internet. So whether they have Googled it or like by default they have given the answer. That was my one of the question. That's it.
Okay, our speaker is little bit taking long time. So what we do is we can advise her to present the results in our institute. So what happens is that once you present the institute, results in institute, they'll know what are the banned FDCs, what are to be used, what are this, so that you get your attention in your institute. Okay, thank you. We'll call for the next.
Now may I request Dr. Madhurima Roy. Dr. Madhurima Roy, please. So as we are running short of time, we request our judges, because now I request judges only to ask question.
May I start, sir? Yes. Good morning, everyone. I am Dr. Madhurima Roy, and today I will be speaking on the topic Knowledge Attitude Practice Study on use of levothyroxine in pregnant hypothyroid patients in a tertiary care hospital in Eastern India. Slide is not getting changed. Excuse me. Okay. Yeah. Okay. So what is the rationale behind my study? Hypothyroidism in pregnancy is a known risk factor for causing feto-maternal complications. Particularly, it causes interference to normal brain development in fetus. However, this grave complication can be avoided with the help of levothyroxine, which is a standard medication for hypothyroidism. The knowledge, beliefs, myths, and misconceptions about hypothyroidism can influence the pattern of levothyroxine intake and the overall clinical outcome of patients. Through this study, we attempt to explore the patient's perceived benefits and risks, beliefs, as well as knowledge attitude practice of levothyroxine intake during pregnancy. So here we have taken patients who are hypothyroid, who happen to be pregnant, who have been given levothyroxine medication, and we conducted a knowledge attitude practice study to assess the awareness of these patients. This study was aimed to evaluate the level of awareness and knowledge of thyroid disease during pregnancy and to evaluate the knowledge, attitude, beliefs, myths, and misconceptions of pregnant hypothyroid patients on levothyroxine usage. This was a cross-sectional study enrolling 80 pregnant hypothyroid patients attending endocrine OPT by convenience sampling. And this study was conducted from March to May 2023 at ACPICon Medical College. Data collection was done using a predefined, pre-tested CAP knowledge attitude practice questionnaire after taking informed consent from the patients. Statistical analysis was done for the same. Moving on to the results. When we assessed the knowledge-based responses, it was found that it was a major positive response when it came to questions like thyroid hormone test being an important parameter to be tested in pregnancy, or the need for doctor's consultation for a first-time diagnosed pregnant patient with hypothyroid. But in contrast, it was found that 56.2% individuals enlisted in the study were not aware about the role of iodized salt in pregnancy during development of hypothyroidism. 70% of study participants were not aware about the symptoms of hypothyroidism. In attitude-based responses, it was found that 55% of the study population believed that drug need not be continued once the thyroid hormone tests are normal. An overwhelming 73.8% individuals previously diagnosed patients felt that drugs should be discontinued during pregnancy as it harms the fetus. And majority 76.2% of the study participants were not aware about the changes of levothyroxine dose requirement during pregnancy. While assessing the practice, it was found that out of all the prescriptions of levothyroxine medication, 23% of the study population were not taking the medication in spite of being prescribed so. This was due to a variety of reasons, majorly ranging from fear of side effects, taking alternative medication, or disliking the medication, etc. When it came to the practice of maintaining the time gap, it was found that 91.8% overwhelming majority of patients were not maintaining the time gap between levothyroxine and other tablets that were prescribed in pregnancy like calcium, iron, etc. A similar 86.6% majority of patients were not maintaining the time gap between food and levothyroxine tablet. Hence, we see that a significant percentage of pregnant patients with hypothyroidism lacked appropriate knowledge about the disease and were plagued by various myths and misconceptions, leading poor compliance of patients. Findings from previous studies reflect similar study findings to mine. Here we found that majority of pregnant women are aware about the thyroid disorder, but are unaware about the symptoms of hypothyroidism. Most of the study population are unaware about the importance of time gap between food and levothyroxine medication and levothyroxine and other medications prescribed during pregnancy. The timing of meals relative to levothyroxine dose can affect absorption of the medication. Calcium carbonate decreases the effects of levothyroxine. So gap between levothyroxine and calcium carbonate should at least be 4 hours. Iron interferes with levothyroxine absorption and reduces its effectiveness. So 4 hours gap must be maintained between the two drugs as well. In conclusion, I conclude that improved literacy level can only increase knowledge about thyroid ailments, but always cannot ensure the practice of taking proper medication. Similarly, improved knowledge and awareness of thyroid disease or levothyroxine medication always cannot ensure practice of taking medication in these pregnant patients. Hence, public health measures are warranted to improve CAP regarding the disease in this group. This significant lacunae in knowledge and awareness about hypothyroidism can be prevented. This in future means we need to emphasize the need for regular testing during pregnancy, imparting knowledge about practice of levothyroxine intake and knowledge regarding interaction with co-medications, and sharing information about dosage change during pregnancy. Thank you to the organizers and the judges for giving me this opportunity.
So good presentation. What was the most important inclusion criteria you have for selecting the volunteers who participated in your study?
So the most important inclusion criteria was pregnant patients.
Okay, other than pregnancy.
Who were diagnosed hypothyroid.
Other than that. So most important variable, I think as per my knowledge, you have missed out in selecting the volunteers. You have it in your conclusion also.
Literacy, I have.
Did you mention it here? Because without literacy,
No, I have collected the.
what is the literacy levels of your volunteers?
It was 54% of the study participants enlisted were not having any formal education previously.
So how do you expect them to have knowledge about your hypothyroid state during pregnancy?
So I had asked about whether my questionnaire conducted had questions like whether they have heard about thyroid disease before or not,
So
or like whether they have been diagnosed as any thyroid disease before they were pregnant. I had questions which were much easier.
54% of your population will always be for your saying that they don't have knowledge. So other 46%, what was the literacy, literary and education status?
So out of that, most of them were above secondary level education.
This is what is most important thing affecting your outcome.
Yes, sir.
So
Yes,
that should have been discussed better in your results.
okay, sir. Okay, sir.
So no literacy, maximum they may not have. Even having educated and graduates or postgraduates, I think thyroid state, pregnancy,
Yes, sir.
and being ladies, whether they have access to internet. Now, because most of the people are Google
Yes, sir.
patients.
Yes, sir.
So all these things should be taken into consideration while analyzing your results.
Yes,
And
sir.
while selecting the volunteers also, you have to specify
Yes, sir.
whom you are going to select. Okay,
Yes.
so ethics committee approval.
Yes, sir. I
So
have.
next, I think all the have ethics committee approval.
Yes, sir.
Okay. Okay, any questions?
Sir has very well pointed out because the instruction that the levothyroxine is to be taken half an hour before breakfast,
Yes.
and there should be a gap of other medication at least 4 hours. That instruction is given by the prescriber.
So it-
So we have to ensure that the patient has understood these instructions, and only then we can talk about the awareness. So that is one of the important point.
Yes,
Dose requirement of levothyroxine may be high during pregnancy,
yes,
and we usually monitor the dose on the basis of TSH level. Okay, so this is the duty of prescriber to make the patient aware of
yes, sir.
this.
That's why the recommendations are for the prescribers, sir.
That's right.
Yes, sir.
Okay, good.
Any two questions from audience?
Only one question. There's just one question. Who administered the questionnaire?
I administered the questionnaire. I gave to all the patients who were attending the OPD at the endocrine OPD at Arjikon Medical College for hypothyroidism.
So do you identify yourself therefore as a investigator, or the pointer was that the doctors who are prescribing should be should be doing this part, because you are a researcher. Direct contact with the patient may not be the most appropriate. If you are using certain investigator, they should be administering, or their delegated just to understand how GCP works, that you have to have a delegated responsible person documented somewhere, that this person's anything you do in the you should provide the responsibility matrix, and it should be documented.
Another question. So no questions. We will go to next presenter. So you have to take these questions in your stride. We are not
Yes.
like we are not scolding you. We are trying to improve you so that the next study you look better.
Yes.
Okay, thank you.
Thank you.
Well done, well done.
Good morning, everyone. I am Dr. Ipal, second year PGT of Department of Pharmacology at College of Medicine and Shreyashi Hospital. My study mainly based on my presentation mainly based on a study titled an institute-based observational clinical study on efficacy of bempedoic acid in lowering the plasma lipid levels in patient intolerant to statins. First introduction. Statins are most commonly used oral hypolipidemic agents. Bempedoic acid is a newer class of oral hypolipidemic agents, mainly acts by inhibiting adenosine triphosphate citrate lyase, an enzyme involved in cholesterol biosynthesis. Bempedoic acid is a prodrug which is activated by very long chain acyl-CoA synthetase 1 enzyme, and treatment with bempedoic acid is associated with hyperuricemia and other side effects like tendon rupture, increased serum creatine kinase, creatinine, and hepatic transaminases. Available data regarding the efficacy of bempedoic acid is limited. So this study was conducted with an aim to evaluate the efficacy of bempedoic acid as a lipid-lowering agent in statin-intolerant patient in a hospital-based population of Eastern India. Next, materials and method. A prospective observational study was conducted in Medicine Outpatient Department in collaboration with Department of Pharmacology at College of Medicine and Shreyashi Hospital at Kamarhati, Kolkata. Study population includes an adult patient of both sexes who were statin intolerant and visited Medicine Outpatient Department. And inclusion criteria are adult patient of both sexes who were statin intolerant and were prescribed bempedoic acid 180 mg once daily for a period of 6 weeks. Next, study duration. Total duration of study was 6 months from January to June 2023, 4 months for data collection and 2 months for data analysis. Cases were taken 3 days per week, and overall 15 patients were selected for the study, and sampling technique was convenient sampling. Next, data collection. Blood reports were collected from patients to evaluate the changes in their lipid profile that include total cholesterol, non-HDL cholesterol, HDL cholesterol, before and after taking bempedoic acid. All data documented for statistical analysis, and any side effect during the study was also documented. Next, results. Overall data of 15 patients were analyzed statistically, and at the end of the study, after comparing their lipid profile, it has been found that the differences were statistically insignificant except for non-HDL cholesterol, which was statistically significant, though all these values were numerically reduced from the baseline. No such serious adverse effect was reported with bempedoic acid except changes in uric acid level, which was slightly increased numerically from baseline, but differences were statistically insignificant. This table mainly shows the changes in lipid profile parameter that total cholesterol, non-HDL cholesterol, HDL cholesterol, their values at 0 weeks, 6 weeks, and their p-values. And this is the bar diagram mainly shows the changes in outcome parameter, that is lipid profile parameter from baseline at the end of the study period. Like total cholesterol level at 0 weeks 228.76 mg per dl and 6 weeks 165.02 mg per dl. HDL cholesterol value at 0 weeks 41.4 mg per dl and 39.8 mg dl at 6 weeks, and non-HDL cholesterol value at 0 weeks 150.55 mg per dl and 109.02 mg per dl at 6 weeks. Next, this is another bar diagram mainly shows the changes in uric acid level. At uric acid level was at 0 weeks 3.86 mg per dl and at 6 weeks 4.8 mg per dl after taking bempedoic acid. An ultimate conclusion is bempedoic acid is a novel class of non-statin therapy that target the hepatic cholesterol synthesis and has significant lipid lowering ability as therapy. So the ultimate conclusion is bempedoic acid is an effective oral hypolipidemic agent with less toxicity, especially when used in patients who cannot tolerate the statin. And limitations of the studies are single center studies, small sample size, and convenient method of sampling. These are the references. Thank you. Thank you.
So the study was conducted in 15 patients.
Yes, sir.
Okay. So how you have included those patients in the study? What was the criteria that you labeled the patient as statin intolerant?
Sir, as it is a prospective observational study, আমি OPD তে attend করার পর sampling technique was convenient sampling. Cases were taken 3 days per week. So
Okay. You mentioned in your introductory slide that the drug is known to cause certain more problems,
yes, sir.
tendon rupture, creatine kinase increase. Have you looked for these problems in these 15 patients? Because you mentioned about only uric acid is slightly increased.
Because my finding only আমার finding এ শুধু hyperuricemia-টাই noticed আমি পেয়েছি দেখতে পেয়েছি uric acid level change.
And it was no problem regarding the muscles, myopathy.
Bempedoic acid is a prodrug which is activated mainly very long chain acyl CoA, and this enzyme is not present in muscles. So muscular side effects is not associated with bempedoic acid.
Okay.
Subhankar sir, can I ask a few questions, please?
Yes, sir, you can ask.
Okay, good presentation. First of all, some standard questions. Ethics committee approval?
No, sir, I have applied but not get yet.
So please do not do this again, because if you are, when you are dealing with especially prospective patients, when
Sir,
yeah.
Adithan has told the same thing, that it has not been looked into for accepting the presentation, sir.
Well, it's okay. Just mentioning for the future. Okay.
Time, sir.
So
Okay.
number 2, patient, you said all adult patients. Was there an age limit cutoff? Did you do a age-based analysis?
No, sir. All adult patient means যারা hypercholesterolemia patient আছে adult patient is not pediatric age.
Madam, first of all, do not speak in Bengali all the time, because most of the online people are not Bengali. So please ensure you speak in English only. Okay. Number 1. So adult patients means what? Is there an age cutoff?
No, sir. No age cut.
So you're saying 18 to 65, 18 to 75, 18 to 85, anybody?
All adult patient means above 18, 18 patients, especially adult patient.
So you mean to say, so hypercholesterolemia, does it affect the younger patient? How much does it affect the younger patient versus older patient? See, this study could have been better if you had targeted a specific group of patients of hypercholesterolemia. It could be more focused. Maybe comorbidities. Did you see any comorbidities at all with these patients?
Comorbidities, some patients have history of diabetes or in my findings, but
Obviously they will be, but did you analyze them?
Yes, sir.
Did you analyze them? How many patients were of diabetic hyperlipidemia, coexistent hypertension and hyperlipidemia, all those aspects, or anybody with known history of heart, heart disease, or renal, patients of, see, hypercholesterolemia are most of it are secondary ones. Primary ones, the hereditary ones are usually very, very low in number. So most of them will have comorbidities. So please go back and see if you can find some comorbid analysis. Third point was the when it says statistically significant or insignificant, what kind of statistics have you used?
Sir, a PRT test using Excel sheet. I have done the PRT test.
Paired with what? Where is what is the control arm?
Sorry, sir. Don't understand.
Control arm. There's no control, right? Most of your, is it before and after, you're saying?
control arm.
The comparison, is it before, after versus, and most of it, statistics is descriptive.
Sir, my study was before after measurement, after taking giving bempedoic acid before and after.
Did you do any historical control?
No, sir.
You should be doing it. And when you mention, see, there is a movement in the here that bempedoic acid will be combined with statin combinations, and you'll see a number of products which will come up. The question is, how did you decide which were statin intolerant patients? How did the prescriber decide what is statin intolerant?
Sir,
What
patient.
were the criteria for statin intolerance? And what you said the inclusion criteria is that. So there must be something that the prescriber must have seen.
They were basically previously prescribed statin, but they complain various side effects with statin. So their medicines changed.
You have to define statin intolerance properly. This is a specific guideline which states this is statin intolerant. So you have to mention that. And you have to tell how many of patients are due to that type of statin intolerant. There are different types of statin intolerant. It could be myalgia. It could be some myopathy. Whether that is documented, what are the statins? At least if I am taking atorvastatin, I have some muscle pain, I will stop and I will be stamped as statin intolerant. That is not right. So what dose of atorvastatin I am taking, and how minimum dose of atorvastatin I can tolerate. These all are the important issues that need to be mentioned. I think first of all, again, I want to acknowledge that you have done a truthful confession, but as it is not ethics committee approval is there with your study, we cannot accept your study for the contestant. So thank you once again.
Another thing, how many of the audience have heard of bempedoic acid?
Bempedoic acid.
Yes. How many? And what was the reason for selecting this drug for your study?
Sir, bempedoic acid is newer class of drug, non-statin therapy, basically. So,
And how many people are being prescribed statins, percentage of people on statins with this drug?
Sir, I have selected only 15 patients.
No. Sir is asking specifically how many of the patients become statin intolerant and get this bempedoic acid. Do you have any idea of that percentage?
That's more important.
Actually, bempedoic acid causes reduction of LDL-C.
No, that is not.
No, sir. No, sir. I am not.
No problem. But anyhow, best of luck. So next time, no ethics committee approval, don't apply anybody.
Okay, sir.
Okay.
So
Thank you. Good work.
So Dr. Shravan, please. They will do. So don't worry. They will do. First slide ta kore dao. First slide. Please start.
Yeah. So good morning, everyone. I welcome all of you.
You can use just this.
Good morning, everyone. I welcome all of you for my presentation. The topic of my presentation is effect of genetic polymorphisms of microsomal epoxy hydrolase and UDP glucuronyl transferase on plasma carbamazepine levels and metabolic ratio in persons with epilepsy of South India, a cross-sectional genetic association study So, carbamazepine has a narrow therapeutic range of 4 to 12 microgram per ml. And EPHX1 gene, it codes for microsomal epoxide hydrolase, whose role is 11 epoxide. So EPHX1 genetic polymorphism lower the levels of plasma carbamazepine, and the role of UGT27 is there is glucuronidation, and any genetic polymorphism, that means a change in amino acid sequence, will result in lower plasma carbamazepine levels, thereby necessitating a higher carbamazepine dose. Since the frequency of these two polymorphisms is 40% in our population, we have selected these two SNPs in our study. The primary objective is to compare the plasma carbamazepine levels and metabolic ratio between these genotypes of two SNPs in persons with epilepsy. Persons with epilepsy of South Indian origin of age 15 to 65 years on carbamazepine monotherapy were free from seizures for 1 year. Attending neurology OPD were included. That is, at the maintenance dose of carbamazepine were included. So after getting ethical clearance, a 5 ml of venous blood was collected in 10% EDTA tube, and centrifugation was done, and plasma was used for measuring the levels as well as metabolite. The metabolite is carbamazepine 1011 epoxide, and this process was done by reverse phase HPLC. The cellular contents were used for DNA extraction, and persons who are non-compliant, pregnant, and that organ dysfunction were excluded from the study. On statistical analysis, first normality testing was done by using KS test for 3 genotypes, the differences in levels and metabolic ratio. So metabolic ratio was calculated by plasma carbamazepine levels divided by metabolite levels, were done by ANOVA with suitable post-hoc test. Unpaired t-test was used to compare the genotype and levels in dominant and recessive models, as there were only 2 groups in dominant and recessive models. So p-value of less than 0.05 was considered to be significant. On demographic characteristics, so mean age was 30 years, and male were found to be predominant. So it was 64 in comparison with female. So the total N was 115, and the dose of carbamazepine was 600 milligram per day, and levels were 2.86 microgram per ml. And epoxide level was also measured. So that was 1.02 plus 0.62 microgram per ml. So this is regarding the genotype frequencies of 2 SNPs. So this was CC was mutant. Mutant means, so it was found in less number in comparison with wild type, that is TT. So this is 30.44%. Whereas UGT2B7, so TT was 40.87 in comparison with CC wild type. So this is 42.61. So TT was 16.52. So this is in accordance with the Harding rate equilibrium. So influence of EPHX1 on levels and metabolic ratio. In all the 3 models, we didn't find any significance between these 3 models, although CT had higher levels of 3.16 in comparison with CC of 2.46. So similarly, metabolic ratio levels were also measured in all the 3 models. And UGT2B7, so there was also a trend of TT showing higher levels in comparison with CT. So that means mutants have higher levels in comparison with wild type. So this was also not significant, but in dominant model, in metabolic ratio, it was 0.088. So that means CC have 1.35 in comparison with 1.18 of CT and TT. So we combined CT and TT because CC is alone dominant. So there were only two groups and unfair T test was used. So on discussion, study results showed no association between these polymorphisms and levels of South Indian origin. The trend of lower levels in CC genotype was similar to findings by GS et al., although it has focused more on hospitalized patients. So there was a trend of TT genotype having higher levels, pointing towards the decrease in activity of UGT2B7. So metabolic ratio was also not found to be significant. Strength among the study is patients who took only carbamazepine monotherapy were enrolled because it was the other drugs involved in metabolism of the drugs were excluded and limitation full sample size was not achieved due to COVID pandemic. We calculated to be 150, but we could achieve 115 patients due to COVID pandemic. So to conclude, our study results did not find any association between the genetic polymorphisms and levels and also the metabolic ratio in epileptic patients of South Asia. So these are my references. So thank you once again for the opportunity.
So thanks for your presentation.
Can I ask a question?
Easy to the study in pandemic and the procedures are very complicated and long. So why do you want to do this? Why do you want to with reference to those polymers, and why you took only those two?
Actually, previously there were findings in our population like 3A4, 3A5 enzymes involved in the metabolism of the drug. So that were not shown to have any significance. So since these two were involved in the metabolism and also having a higher minor frequency in our population, so we selected these two associations.
So this was not done earlier in top.
No, no.
So you didn't find any references where there were between your polymorphism and the patient anywhere.
In Chinese population, I could find no.
Because there is so much physiological concern.
Yes.
So you did find any reference where these polymorphisms for others.
Yes.
So just to prove that they are not responsible.
Yes.
So any 2%, only 2. And short. Anyone online?
Can I ask
Yes,
a question?
Yes, madam.
Yeah. No. Have you taken informed consent?
Yes, yes, ma'am.
Sorry.
Yes, ma'am.
You've taken. You had children also 15 years. So what did you do for them?
Actually, we did.
You said 15 to a 65 or something, no? So
actually, we did include children. Ma'am. So while framing the protocol, we wrote it like that, but we didn't include children. So all were above 18 years.
But in protocol, what was your informed consent process? Because you included people.
Yes.
So what was your process for informed consent?
Actually, there was assembly.
You had it in the protocol.
Yes, yes. But in that 115, no one will.
That is, you have not recruited anybody to 15 to 18. That's okay. But the process of informed consent, was it mentioned in your protocol?
Yes, yes.
That was
Separately. Okay.
Thank you, madam.
What madam is trying to say is there's this process of what is called the ascent in less than 18 years. So you when you're including that kind of age group, you need to mention that parental consent as well as assent of the study participant needs to be taken. That is, am I correct, ma'am? Or is it something else you want to-
correct only. Because it was not mentioned. I think from next time they should talk about
ethics committee approval, informed consent, and CTRA registration. Because before the first patient is in, you need to register with CTRI. So, yeah, that's it. Thanks.
Thank you.
One last question. What is the implication for the clinical practice of the epileptologist or the neurologist from his study? Can you draw any conclusion out of this?
While prescribing, they do not worry about these two different people, and usually all patients who responded were in the.
Sorry, can't hear you. Can you be closer to the computer mic?
Yes, sir. So these clinicians need not be worrying about these two SNPs when prescribed to the population of South India, and all were in the therapeutic range. All patients were in therapeutic range, and usually clinicians will prescribe based on their therapeutic response. All were maintaining the same dose for 1 year. Okay, thank you. One last short question. Thank you for your nice deliberation, particularly on this topic, that is your molecular pharmacology, and this type of work is carried out by Pingali, that is required, I know very well. So thank you for this. Just I want to know from you that we have estimated carbohydrate and metabolite. So the method of analysis was same for metabolite as well as the certain compounds. What was the RT? Metabolite and certain compounds. Like around 7 minutes. 7 minutes. So what was the how we have estimated metabolite? Like metabolite was purchased, the powder was purchased separately, and we ran in that for same procedure, reverse testing. Thank you. Thank you. Now, thank you, Dr. Shobhan. Now may I request Dr. Sahu.
Good morning. Good morning, everyone. Myself, Dr. Subhankar. I am going to present on the topic treatment reconciliation in Parkinson's disease patients, with particular reference to wearing off and motor fluctuations, a registry-based prospective observational study. So, coming to introduction, as you will all know that Parkinson's disease is the second most frequent neurodegenerative disease, and the neurological hallmarks is striatal dopamine deficiency, and Parkinson's disease is characterized by bradykinesia, rigidity, rest tremor, and non-motor symptoms. And we all know that levodopa is the gold standard for Parkinson's disease, and on long-term use of levodopa, it can lead to wearing off or end of dose deterioration. And it is managed by levodopa or levodopa plus carbidopa therapy, or addition of other dopamine agonists, anticholinergics, NMDA antagonists, COMT inhibitors, and MAO-B inhibitors. And registry-based study is either a clinical trial or non-interventional study. And basis of registry-based study, we can find out the effectiveness, safety, and tolerability, and quality of life, and adherence. So this study is designed to investigate the wearing of effects in Parkinson's disease patients and their pharmacotherapy and outcome. So this aim is to study the wearing of effects in patients of Parkinson's disease, their pharmacotherapy and outcome. And the primary objectives of the study were to assess the frequency and pattern of treatment emergent wearing off phenomenon and motor and sensory fluctuations in Parkinson's disease patients. And second objective is that to identify the medications suspected to cause them, the onset, clinical presentation and management, to gather evidence for effectiveness of prescribed treatment in these patients, vis-a-vis comparing the outcome of different regimes used to treat them. and to monitor safety and tolerability of the prescribed treatment. And the secondary objectives are to establish a dynamic registry for Parkinson's disease patients, to monitor treatment adherence and to study impact of suboptimal adherence, if any, on treatment outcomes, to study how the quality of life of such patients is impacted by the disease or the treatments prescribed, to explore how such patients are managed in the emergency health situation, and to find out the therapeutic outcomes of treatment with newer agents. So, coming to materials and methods, this is a prospective observational registry-based study, outcome study, conducted at Department of Clinical and Experimental Pharmacology, Kolkata School of Tropical Medicine, Kolkata, in collaboration with Neurology OPD Medical College, Kolkata, and private clinic of one consultant neurologist in Kolkata over a period of 24 months, from January 2020 to December 2021. And the subject enrollment for 6 months and follow-up was for 12 months tentatively, and the data analysis and report writing for 4 months. And a convenience sample of at least 100 was proposed, and the study population is all consecutive criteria eligible consenting patients attending the neurology OPD of Medical College Kolkata and private clinic of one practicing neurologist, and all the adult subjects of either sex, idiopathic Parkinson's disease duly diagnosed by the clinician and attending the neurology clinic regularly, and those are receiving drug therapy for Parkinson's disease for at least 1 year and willing to take part in the study were included, and consented for the study were included in the study, and the patients, those are having the history of wearing of and motor fluctuations, were excluded from the study. These are the study parameters and tools used in the study. First of all, basic demographic details like age, sex, occupation, weight, height was taken, and cognitive assessment, rigidity, tremor, etc. According to UPDRS, that is Unified Parkinson's Disease Rating Scale, was used, and wearing of onset wearing of questionnaire 19 was used in the study. Quality of life was taken by Parkinson's disease questionnaire 39, and adverse drug reaction monitoring using Indian Pharmacopeia Commission ADA reporting form, causality assessment by WHO UMC's causality assessment scale and Naranjo's algorithm, severity assessed by modified Hatch severity scales, and medication adherence by Morris scale. This is the study technique that patients were enrolled taking after the informed consent. Patients' data were filled in the case record form and data collected at baseline. Then at the first follow-up was done in 1 month, second follow-up 3 months, and third follow-up was done in 6 months. And coming to the data management and statistics, data were collected and then statistical analyzed. Descriptive data was represented as mean or percentages, and demographic categorical data were possible analyzed with parametric and non-parametric tests. And data were analyzed by using Microsoft Excel and Graphpad Prism 9 software. And the result and observation shows that total idiopathic Parkinson's disease patients were 111 in our study, and incidence of wearing off was found to be 40.5% among idiopathic Parkinson's disease patients. And the mean age of idiopathic Parkinson's disease is found to be 61.85 plus 7.2 years, and median age was found to be 62 years. This was a gender-wise distribution of wearing off among idiopathic Parkinson's disease patients. In case of male, there is development of more wearing off than female, and this is the in the right side, that is age-wise distribution of wearing off and developed among idiopathic Parkinson's disease patients. In less than 65-year age group, it is more developed wearing off than in more than equal to 65 years. And this table shows the comorbidities among idiopathic Parkinson's disease patients. Hypertension was found in case of to be 33.3%. Diabetes mellitus was found in 33.3%. Hypothyroidism 16.7%. And this is the table shows the wearing off among idiopathic Parkinson's disease patients. At baseline, it was 0 due to exclusion criteria. And in fast follow-up, there is development of 14.4% of wearing off. In second follow-up, 18%. and in third follow-up 8.1%. So this is the table shows the wearing onset time, and we use Fisher exact test to find out from the baseline to second follow-up, from the baseline to third follow-up, everything is statistically significant. And these are the characteristics of wearing off among the patients of idiopathic Parkinson's disease. Tremor was found to be 28.8%, and all this next to it is slowness of movement, that is 70.5%, and the drops in all of the subjects, there is use of levodopa, and next to it, along with it, triacylphenydyl primepactal were used. This is the table showing the different parameters at baseline and follow-ups. At baseline, the MDS UPDRS score was 15.02, and in the first follow-up, it was found to be 13.68, second follow-up 10.53, and MDS UPDRS score is decreasing from baseline to third follow-up. And 5 months ANOVA revealed that the p-value is significant, so that there is significant improvement in MDS UPDRS score. And MMS Morisky scale so reveals that at baseline it's 7.15 and first follow-up 7.2, and the MMS score is also improved from the baseline to third follow-up, and Primus ANOVA reveals that it is statistically significant. And the PDQ-39 score reveals that baseline is 180. It is also increasing improvement in PDQ-39 score from baseline to third follow-up, and Primus ANOVA reveals it is statistically significant improvement. After that, we have done the post hoc analysis by Wilcoxon matched pair side rank test, and the comparison is statistically significant. This is a table showing the adverse reaction idiopathic Parkinson's disease patients, and the WHO's UM scale and NARA causality assessment scale reveal that 36.4% adverse reaction were probable in category and 63.6% were possible in category. Then, according to Hartwig's severity scale, all the ADRs are mild in category. Coming to discussion, present study was designed to assess wearing of onset and its pharmacotherapy to evaluate patients' outcomes in terms of MDS UPDRS score, safety, tolerability, medication adherence, and quality of life to explore treatment in emergency situations. It was also to explore the comorbidities associated with Parkinson's disease, and there is an attempt to make a registry of such patients. But due to COVID-19, we failed, and the diagnosis.
We can conclude.
These are the discussions, and due to COVID-19, we cannot make the registry. So in conclusion, Syndopa was mostly associated with wearing of phenomenon, and most common comorbidities were diabetes and hypertension in the study, and anti-Parkinson drugs were very well tolerated, and adverse reactions were mild in intensity, and Syndopa was mostly commonly associated with the wearing of management, and early treatment with levodopa and combination with carbidopa and newer therapies can improve the MDS UPDRS score, MMS score, and PDQ-39 score was observed in the study. And there is a definite role of clinical pharmacologists in treatment reconciliation. We should do treatment reconciliation advice for the management of these cases. Vijay, thank you.
Great work. Good clinical pharmacology. Pingali had a last conclusion. Okay. So any questions? Yes.
Yes. I follow the patients. In this study, I want to initiate a registry, make a registry. On the basis of that registry, I have to do registry-based studies that to find out the effectiveness, safety, tolerability, and we can use the registry for further research also. But due to COVID-19, we failed to initiate the registry, and these are the data I found.
In difficult times, yes, you will continue. Can you explain the difference between wearing off on phenomena, off phenomena? You have discussed only about the wearing off. Any dietary advice was given to these patients?
Wearing off is after taking long term of levodopa, there is long term of levodopa, there is
you have mentioned in your data.
There is increase in the symptoms after long term use of levodopa therapy, and that is called the honeymoon period is over. So the patient developed wearing off, and that was managed by the clinicians by either modifying the dose of the drug, either levodopa dose modification, or adding some dopamine agonist like ropinirole, pamipexole, etc.
What was the most common thing of prescription to deal with the wearing off?
Only 45% there is development of wearing off.
So what was the main issue?
Every patient are on levodopa therapy.
Okay.
And also adjunctive to that, they are taking the triaxpendil, some patients taking the ropinirole, some patients pramipexole, etc. But
this dopaminergic agonist along
with that.
Because there are number of
After that, improvement in the MDS-UPDR score also, and also the PDQ-39 questionnaire score. There are
Yeah, so same question. You mentioned about concomitant diseases. Concomitant medications, have you done some analysis? I didn't see the data. Probably it is there. Other
because we have a running out of time, sir. We'll take your question in the chat box and we can discuss later.
This study was also published in JCDF.
Now may I request Dr. Shreyashi to the final presentation.
Good afternoon, everyone. I'll be presenting a study titled So I am presenting a study which was conducted at our department at the School of Tropical Medicine, not only our department, the entire institute. So this was a point prevalence study to quantify antimicrobial utilization and determine the patterns of antibiotic use at a selected healthcare facility in Eastern India. So this needs no further elaboration. Antibiotics, as we know, are the most commonly prescribed drugs, and they are amongst the most frequently misused drugs also, and they significantly increase healthcare costs if used irrationally. So this study was a part of a national project that was conducted in collaboration by the NCDC, the National Center for Disease Control in Delhi, and the World Health Organization. It was a part of the antimicrobial resistance surveillance project conducted in 33 centers across the country, of which our institute was also a part. So here I am only presenting the data that presenting the results of our institute. So this was a point prevalence study. The rationale behind conducting this point prevalence study is that in most low and medium income countries, continuous data collection is at times difficult because we have the people engaged in healthcare are already overburdened due to the workload, and also there is a lack of adequate resources. So in this setup, a point prevalence survey methodology comes up as an alternative method. It helps to collect data at a specific point of time, and thereby it helps in comparison over time. repeatedly 2-point prevalence studies. And it is an established research method used worldwide, and it encourages standardization and facilitates the comparison of antibiotic use over time. And this comparison can be between hospitals, between districts, countries, regions, etc. So before proceeding with the study, we had taken ethical approval from the Central Ethics Committee of NCDC, as well as from the local institutional ethics committee. Data collection was done by our postgraduate students, by the junior and senior residents. And before they conducted the point prevalence study, they were imparted training on a previous occasion, where we had detailed them on how to collect the data and how to collect all the information from the tickets, from the bedside tickets. So pre-validated Google Forms were used for this survey that was circulated to all the data collectors on the day of the collection. All responses were collected centrally at the site, and they were compiled, and then data was cleaned at the site itself. Now, this data was sent to the national centers and as well as analyzed at our local center. So the inclusion criteria for this study was, we included patients who were admitted to the acute care inpatient wards. We did not take any, I'll go for the inclusion first. So acute care in inpatient wards, patients who had been hospitalized as an inpatient at or before 9 a.m. of the day of collection. We only took account of the antibiotics that were administered either orally, parenterally, rectally, or through inhalation, and any antibiotic treatment that was ongoing on the day of the collection at 9 a.m. Only those antibiotic information about only those drugs were collected. Exclusions, patients or prescriptions from the outpatient departments were not collected for this data. Discharged patients who had been discharged on that day waiting for transportation were excluded. Topical antibiotics were excluded, and any treatment which was initiated after or any treatment which was discontinued before 9 a.m. of the day of collection was excluded. So data collection was done on the 22nd of December, 2021. So this is a very small hospital which caters primarily to infectious disease. So we had only 8 wards that we surveyed. So there was a total of 4 male and 4 female wards. On the day of data collection, 47% of the beds were unoccupied. 1% of the bed was ineligible because he was awaiting discharge. Eligible patients not on antibiotics comprised 14% of the beds, and 38% of the total patients were on antibiotics. So total admitted were 85 patients, of which 84 were eligible, and total patient on antibiotics were 61. Total antibiotic prescriptions on that day were 118, with average antibiotics per eligible patient being 1.4 and average antibiotics per patient on antibiotic coming to 1.93, close to 2. So patients on antibiotics, as I said earlier, total 61, of which 16 patients were on 1 antibiotic, or all around 39. A huge number of patients were on 2 antibiotics, and 6 patients were on more than 3 antibiotics. Patients with parenteral antibiotics, total prescriptions were 55, oral antibiotics 65. Those on empirical therapy coming to a huge number, 94%, and definitive therapy 5%. So these are the diagnoses for which we were collecting data, were pre-specified. So community acquired infection, 80% of the cases were being treated for community acquired infection, and only 3% was hospital acquired. We do not have any surgical wards, so no antibiotics were prescribed for surgical prophylaxis. 15% for medical prophylaxis, and 1 patient was the diagnosis was unclear. It was not mentioned. So these are the topmost antibiotics that were prescribed, beginning with doxycycline, 24 patients, gentamicin, followed by piperacillin tazobactam, ceftriaxone, and cotrimoxazole. So as you can see, among the 5 most prescribed antibiotics on that day, 3 were from the access criteria, from the access list, and 2 were from the watch list of the WHO. 29 prescriptions did not conform to any specified recommendations or existing standard treatment guidelines on that day. So this table shows us the total number of prescriptions that were from the aware list. Access list, there were almost half of the prescriptions were from the access list. Watch list, 42%, and from the reserve category of antibiotics, 6%. Double anaerobic cover, 2% of 2 patients were receiving antibiotics for double anaerobic cover, and double cover for gram-negative, 28 patients. So a routine surveillance for antibiotics is also conducted in our institute. So for 2021, the access watch and reserve criteria category were 38, 51, and 9%, whereas for PPS on the same year, on that particular day, we found access criteria was more as compared to the routine surveillance data. Watch was almost similar, 42%, and reserve category almost comparable with 6%. The most prescribed antibiotics were different in the two different studies, probably because in routine surveillance, we are also including the outpatient data. So we see more of drugs like azithromycin, erythromycin, etc., which were not seen in our PPS study. So this just gives us a cross-sectional view of the antibiotics which are prescribed on that particular day. So to conclude, I would like to say that we have seen a relatively high use of antimicrobials in our study. This may be because our institute is dedicated to infectious diseases. So we expect more antimicrobials being prescribed over here. This study demonstrated the feasibility of conducting a point presence study, the ease of conducting such a study with a paper-based medical record system. And it provided baseline information, and this information is now being used to formulate the hospital antibiotic policy. We have already formulated one. It is in the process of being implemented. Once it is implemented, we are planning to conduct another PPS study to see how the changes have taken place over the period of time. Thank you.
So thank you. Any questions for this person? I just want to ask, what did you find unusual about the results? Did you find anything unusual? And if you did, what was it?
So,
something that you would not have expected.
So actually, maybe because this is a highly specialized institute focusing on infectious diseases. So we had expected that we would not find too many prescriptions which are not conforming to the recommendations of the standard treatment guidelines, because that is part of the training that is being imparted, or that is something which is followed. But then that also means that we need to formulate maybe separate antibiotic policies for our centers also. The standard treatment guidelines may not align to what the local local antibiotic requirements are, or what the supply is, because most of these drugs are actually being procured from the hospital supply. So that may be something which which has come out from the study.
That's interesting, very interesting. What I found a little odd was that more than 90% of these patients are being infected. As an infectious disease hospital, I would expect a larger number of patients to have been actually the microbes to have been identified, and treatment lines to be identified and sensitive.
So the one explanation that I can offer is that because we were just looking at data on one day, we were not concentrating on how many days the patient has been already admitted. So data which has been, I mean, the patients were, the data which has come here, I mean, a major contribution of that data may be from patients whose diagnosis has not been made yet. We do not know when they had been admitted. I mean, whether they had been admitted the previous day or they have been there in the hospital for a long time. Because, so, sir, I would always incorporate a period, like when was the patient admitted, how many days it has been. So that would be.
Thank you.
Sir, we had taken that. In most of the cases, the culture sensitivity was done, but they were awaiting the reports in some cases.
For how many people sensitivity and
yes, sir.
Based on this prescription was modified from the previous time. Right.
Yes, sir, we did it on one point. So maybe next when we are doing that.
Would have been there
yes.
So thank you all.
Thank you so much.
Wonderful effort. We're not seeing any might be coordinate coming here contributing. So we'd like the number to grow. So the final announcement will be made at the last. There are two reasons for this. We have some time to discuss. And when we make the announcement at the last, we hope all of the competitors will be and all the chairs will be filled up. And organizers will be very happy seeing all the chairs. This is our duty to see that we keeping the same smiling face tomorrow and later. Thank you. A good opportunity for us.
Thank you, sir. Thank you. Thank you for your kind support also, sir. Professor C. Prabhakar Reddy from Nizam Institute and also Professor S.P. Dhaneria, sir, for valuable time. And now we are moving towards the next session, and I think that will be a great opportunity to learn, because already in this scientific session, there are lots of very good papers, but we found that there are 2 papers presented without ethics committee permission. So ethics is something which is very important for us, and the Symposium on Clinical Research and Ethics. And for that, we have joined in the field of endocrinology and clinical medicine in India, is a reputed teacher worldwide. We are really fortunate to have you with us, sir. So may I welcome Professor Subhankar Chowdhury, sir, who will kindly chair the session. With that, also we have another great scientist, experimental pharmacologist, Professor Tapan Kumar Mondal. He is currently President of Indian Pharmacological Society West Bengal chapter, and he is also the Vice President of Indian Pharmacological Society. So to chair the session, may I welcome Professor Tapan Kumar Mondal, sir. Now may I request our respected chairpersons to start the session.
Thank you, Dr. Sambo. So I am really thankful to the organizer, particularly Dr. Sambo, for inviting me to what is important conference. That is, at this point, important. The clinical pharmacology and patient Symposium, clinical research and ethics. So we have 3 eminent speakers at this symposium. Number 1 speaker, Pharmacogenomics to support drug development research, and it will be delivered by Professor Adithan. The organizer is honored to honor Professor Adithan to be with us online mode to deliver this important topic, pharmacogenomics to support drug development research. So we need not introduce Dr. Adithan, who is the eminent scientist in the field of pharmacology, not in India, in abroad also. So I will request Professor Adithan to deliver the lecture.
Sir, will you share the screen, sir?
Okay, 1 minute.
Or otherwise we can share, you can tell us to change, we can change that. Hopefully you can see this, our screen, sir.
Okay, kindly you share the screen. I have some technical difficulty.
We are sharing, sir. You will tell us to change, we will change, sir.
Okay, okay.
Thank you, sir.
So I would like to thank the organizers for giving me opportunity. Dr. N.R. Biswas, then Dr. Tripadi, and I am also able to see many of my old colleagues. Now, next 15 minutes, actually this has to be a 1 hour topic, but I will try to do it justice within 15 minutes. This is the pharmacogenomics to support drug development research. Next slide. Next slide. Actually, in this 15 minutes, I am going to cover the time factors, cost factors in drug development overview, then
the incorporation of pharmacogenomics in various phases of drug development. This is what I am going to attempt in these 15 minutes. Next one. Next, please. Yes. As you all know, drug development is a laborious and time-consuming one. You start with 10,000 compounds and we left it only one approved drug. Next slide. And it takes about 12 years to bring the average NCE to commercialization. Then nearly 1 billion we have to spend. And it happens, $200 billion may be attributed to compound failure. Next slide, please. The cost of fundamental and clinical testing for NCE is, you can see here as it is shown. The phase 3 is highest. It is 27.1. The lowest is animal model testing. It is 1.66 million US dollars. In case, if let us say, next slide. Next slide. In case there is a termination of drug clinical trial in the phase 2 or phase 3, it costs a lot of money. That this is due to lack of efficacy and safety concern. So we have to take care in designing the clinical trials, recruiting the subjects, so that the study cannot be aborted at the later phase, either phase 2 or phase 3, which will be very, very expensive for us. Next one. Next one. This slide you can skip. Next one. Next. So first one is drug target identification. This can be done by in vitro study as well as the animal study. Here, if we can say, all of it we are aware that drug target may be an enzyme or a receptor or transporter or a protein in signal transduction or any protein produced in a pathologic condition. It happens that proteins, that is a receptor, transporter, are polymorphic. They are controlled by gene. If there is a polymorphism in the genes encoding these proteins, then there will be variation will be there. For example, polymorphism of beta-2 adrenaline receptor gene and the P2Y12 receptors can lead to inconsistent result in preclinical and clinical studies. So we have to be very careful. Thus, at an early stage, the target can be characterized based on pharmacogenetic studies by in vitro or by animal study, combined with the proteomic and suitable drug compounds in selecting the further studies. Next slide. In phase 1 study, which all of you know, that the main purpose is to establish the safety of the drug. Here we include the subjects, healthy volunteers, but to say whether they are healthy or not, we have to do pharmacogenetic testing, ideally, because majority of the problems are come due to the pharmacokinetic problem. Then, of course, it comes the response. It can be used. So if you do the pharma testing, we can use this knowledge for inclusion or exclusion criteria when the metabolic pathway of drug is done. But on the other hand, if you are going to do exploratory study, we have no idea about what is the drug metabolism, enzyme, all these things. Here, we cannot use the pharmacogenetic principle because then it will be biased, we'll be missing many things. So in case of exploratory studies, whether it is phase 1 or phase 2, whatever may be the things, pharmacogenomics has no role. Only after we get some idea about the metabolic pathway, all those things, then we can include the pharmacogenomics. Next slide. In come to phase 2 and phase 3 study, the phase 2 trial test if the disease responds to a new treatment or not. That is a major purpose. While phase 3 trials test if the new treatment is better than the standard treatment. Phase 2 and phase 3 trials are confirmatory phase. Patients with disease interest are studied to provide further information on dose ranging, and to establish definitely the benefit risk ratio of the new drug. So if you have some idea in the phase 1, then it can be incorporated in the phase 2 and phase 3 clinical trial also. Next slide, please. The advantages of clinical trial using pharmacogenomic knowledge are many, but there are certain restrictions also there. Pharmacogenomic testing during clinical trials has significantly reduced two important concerns: efficacy and safety. Dose range selection and dose modification, exposure and doses higher than otherwise possible only if you apply the pharmacogenomic knowledge. When you use the pharmacogenomic knowledge, the study subjects, number of study subjects will be smaller number relatively, and the duration of the study also will be shorter. So another advantage is it eliminates unsuitable drug candidates and therapeutic targets at the early stage of the development only, so that the failure at the phase 2 or phase 3 can be avoided. Then optimize risk-benefit profiles, explanation of outliers, and interpatient variability in pharmacokinetics. Interventional variability can be reduced, then reduction in the number of dropouts. Dropouts also can be reduced. Then another benefit is when you use the pharmacogenomic knowledge in our study clinical trials, then we can compare it with the other ethnic population also. Next slide, please. There are few disadvantages, but that is also important. When you apply pharmacogenomic knowledge, we use the selected individuals. So sometimes we may not get inadequate information about potential variability in the drug population. It is not possible to investigate safety and efficacy, even lower dose of genotype is good. Then multiple enzymes are frequently involved in drug metabolism and transport. But in pharmacokinetics, in pharmacogenomics, if you test, it is difficult to test for all the alleles. So that is another limitation. When you use pharmacogenomics, then we become overconfident. We may escalate the doses, and the efficacy also may be higher side. We will conclude. Then further, erosion of short-term and long-term safety data. So design may overlook the importance of pharmacodynamic polymers. So pharmacodynamics is very, very important, and of haplotype. Next slide, please. Then in this, that is about the specifically for phase 2 and phase 3 trials. And about phase 4 clinical trials, here we analyze the report of adverse reactions with pharmacogenetic test. Most important concern when integrating pharmacogenetic in drug development is the fact that rare or delayed ADR are unlikely to be observed during clinical trials. Example, perexlin induced neuropathy was not evident during clinical trials. But when you follow them for about 20 months, the side effect, neuropathy side effect become prominent. So it is essential that the pharmacogenetic testing should be done in the phase 4 trial also, and beyond that maybe. In order to harness the potential benefit of pharmacogenetic studies, will have to continue well beyond the approval of a drug into its post-marketing surveillance period. Next slide. Now comes the regulatory issues. Regulatory issues, as I went through the website of CDSCO, it is not very clearly, they did not spelled out. So I have to go to the FDA website to see what they are telling. This updated one, yesterday only I went through the website. It requires submission of pharmacogenetic data during drug development. But it is not intended to provide definite evidence of safety or effectiveness. So it is only a recommendation one. So phase 1 and phase 2 studies considered these guidelines are often described as exploratory in that they are not intended to provide definite evidence of safety and the effectiveness needed to support drug approval. Nevertheless, PGX studies can provide mechanistic support and be applied in the design of analysis for later trials, potentially improving their efficiency or likelihood of success if the genetic factor can help predict the likelihood and magnitude of response. Next slide, please. This I already mentioned. Next slide. This is from FDA recommendation. They come out with a table where pharmacogenetic association have been listed. Section 1, where pharmacogenetic association for your data support therapeutic recommendation for about 60 drugs are given. Then association with the data indicate a potential impact on safety or response. About 20 drugs are listed. Then pharmacogenetic association for your data demonstrate a potential impact on pharmacokinetic properties. About 40 drugs are given. This table is being continuously updated. So if you get interested, you can go to the FDA website and see this one. Next slide. Then about the drug labeling. Drug labeling, when I was a student, at time it was few only. Now the table shows pharmacogenomic biomarkers in drug labeling has to be there. At least 570 drugs are listed there. It has a long file. File is 3.67 MB. And the list is they go on adding this. Next one. Then FDA, that is FDA, European, and the PMDA, that is Japan, all expect the sponsors fully investigate the potential effect of polymorphism on any enzymes or transport that play a major role in drug metabolism or clearance. All three agencies also recommend that examining the effect of genetic polymorphism on pharmacodynamic endpoints. Mostly we worried about the pharmacokinetics, but the pharmacodynamics should be considered. In general, it is recommended that if genotypes of predictive drug effects in early trials, enrichment or stratification strategies should be considered to increase the representation of genotype of interest in subsequent pattern studies. Although the guidelines on pharmacogenomic, pharmacokinetic research have matured rapidly over the last few years, those surrounding pharmacogenomic, pharmacodynamic assessment are considerably less well developed. Next slide, please. This is the where CDS were such. Finally, only this information I could get. Whenever they give permission to any drug company to carry out the clinical trials, this is the advice they give. At least 50% sites from government sites. But second part is important. The firm should comply with the requirements for sampling of DNA biomarkers for pharmacogenomic study and shipping to other countries. This is the only advice they give to the sponsors. All the other things are about ethics committee, other things. So the relatively CDSCO is not giving so much importance for pharmacogenomics in drug development. Maybe I made a mistake in the yesterday website. This is what I could gather. Next slide. Generally, DNA sample collection also there are certain guidelines for clinical trial. From an operational perspective, DNA samples must be collected before any pharmacogenomic work starts. A recent survey showed, this is from Western data, 80% of the companies routinely collect DNA samples from subjects for phase 1, phase 2, and phase 3 studies. Approximately 20% companies routinely collect DNA samples as a part of phase 4 studies. However, support for pharmacogenomic sample collection is not universal. For example, Brazil and Thailand, they say don't collect any DNA sample during clinical trial. China says, yes, you can collect, but do not transport to outside China. So these are the variabilities there. I think I understand from the previous slide that India is not permitting the transport of DNA outside India, but we have to follow certain guidelines. Next slide. So to conclude, Pharmacogenomics hold the promise to drive most efficient, effective drug development. Incorporating pharmacogenomics into drug development is associated with a number of challenges. Some are being addressed, whereas others still need to be addressed. It is often difficult to recruit enough patients when studying small genetically defined subgroup of patients. Hence, novel trial designs that allow smaller sample size and faster enrollment is needed. A number of alternative trial designs, like adaptive clinical trials, randomization, delayed start, early escape, or such alternative trial designs may overcome the limitations of sample size requirements for pharmacogenomic study incorporation in the clinical trials. Each trial design comes with a specific advantage and limitations. So careful selection of the appropriate study design is very, very crucial if you are planning to use pharmacogenomics in your clinical trials. Then most important is we need collaboration between industry, academia, and regulatory agencies to improve the success of applying pharmacogenomics in drug development. These are the things I want to share. I thank the opportunity. Again, next slide. I thank you very much for giving the opportunity to share my expertise. Actually, almost for 5 years, I did not attend any conference. This is a chance to look at the younger faces. Thanks a lot. Thank you.
Thank you, sir, for your nice invitation. So this is open for discussion. 1 or 2 questions from the audience.
Yes, please.
Any question? No question. Thank you all. Thank you, sir.
Okay, thank you very much. I again thank the organizers, especially Biswas, Tripathi, and other organizing secretaries for giving the opportunity. Thanks a lot. Bye.
Thank you very much. We have exciting opener to the session. Now we go on to another very important aspect in clinical drug development, which is setting up a BAB study center. Challenges and solutions. It will be tackled by none other than Dr. Usharani, who heads the Department of Clinical Pharmacology and Therapeutics at the Adithan Medical Sciences in Hyderabad. So over to you, madam.
Yeah. I thank the organizers, especially Dr. Biswas, Dr. Tripathi, and of course Shambhu for giving me this opportunity. I hope my slides are visible and I'm audible.
Yes, audible.
Yeah, okay. So the topic given to me was setting up a BAB center, the challenges and solutions. And yeah, and this has been pretty close to our heart because we've run the BAB studies for, for quite a long time. So I would just like to give my presentation with a little introduction. The current BABA scenario in India, the regulatory requirements for setting up a BABA center, what are the potential challenges, the key solutions, and a small take-home message. Of course, we know that bioavailability refers to the rate and extent to which an active moiety or a drug or metabolite enters the systemic circulation, thereby ascertaining its action. And that is defined by actually 3 pharmacokinetic parameters, AUC, Cmax, Tmax, whereas bioequivalence is actually done to establish the absence of statistically significant difference in the rate and extent of absorption between the reference and the test product as per the new NDCT rules. So for this, we need to have some bioavailability and bioequivalence centers set up, either to do the clinical aspect or to do the analytical aspect or to do both. So the current scenario, we know that India has been the pharmacy capital of the world. We are exporting nearly 200 or to nearly 200 countries. We are exporting generic formulations, and we have around 77 CDOS approved BABE centers. And this is because many drugs are going off patent in the coming 10 years, and India's population, we have a good database of healthy volunteers to do BABE studies. And the centralized registration and submission is done using the Sugam portal. And of course, we have good regulatory guidelines have been laid down, and we need to follow some minor country-specific variations when we are doing it for other countries also. So we have actually 3 pillars for doing BABE studies. The main one being the clinical pharmacology unit. Then we have the bioanalytical unit and the quality assurance unit, and all the 3 need to function hand in hand. Otherwise, studies will go haywire. So we have some regulatory requirements for setting up BABE centers, which very clearly state that they should be registered with the CDSO by applying through a CDSO form, and you need to have some payment being made. And they should have an in-house or associated ethics committee. It can be an independent ethics committee or an institutional ethics committee. However, its more important aspect is the oversight on the bio availability and the BABE studies at a center by the ethics committee, which is giving approval. So this is one thing which we have seen has been lacking in some of the BABE centers, where the ethics committee members don't oversee what is actually happening. And the NDCT rules actually go ahead saying that you have detailed description on how to apply for a BABE center. You have various chapters which discuss the requirements, the registration and the application, how to import the drugs, and how to actually do the analysis, applications for that, and the guidelines for conducting. However, we are more concerned with the registration, because all the BABE centers need to be registered, for which you have to apply using the CT form. So which, if everything is fine, you get an approval with the CT09 form, which is valid for 5 years. But if there are some objections, then it is, you need to actually fulfill the corrective procedures you need to do and then resubmit. Or it may be even rejected within 60 days of application, where you can again apply to the central government, and then you can appeal to the central committee and then give your response within 60 days of an appeal. So when you set up a clinical BABE center, the clinical pharmacology department, the clinical pharmacology unit is something which is very important. That is the basic point for doing such studies. And every time you need to have an access control to the entrance, which is once the bag and baggage check is done and the volunteer is sent inside, then they should not come out again unless there's a specific requirement, because everything is there within the unit. Like you need to have washrooms, and one thing which you need to remember is the washrooms should not have a latch from inside. It is only that you can just close the door, but you should not have latches inside, because if there is an emergency, then the volunteer needs to be accessed. So, and then you should have some sort of a calling bell, which we used to have in our unit, where if there's an emergency, the volunteer can press the calling bell and someone from outside can come in. There should be a good dining area for the subjects, because they will be housed for nearly 24 to 48 hours or even more, depending on the drug. The dosing area needs to be clearly defined with the proper seating, spacing, and all that. And then you should have an area for drug supplies, and that should be under the control of the pharmacist. And sometimes we have seen in some places, the drug supply area is kept within the unit where the dosing is being done, and perhaps that is not a very correct procedure. Then you should have a medical examination room to see the volunteer at the time of screening and all that. And then you should have some, area, a small area for centrifugation, sample separation, where the samples are centrifuged, separated, and then they are stored in a deep freezer for before analysis is being done. And then it's always advisable to have an entertainment area for the volunteers, because once they're housed, then they need to have some sort of an entertainment. But that should not include any heavy physical activity. So it should be something simple. And one important thing is between the beds, again, there should be adequate space. I think ideally says between 1 to 2 meters or 4 to 5 feet, because if there is an emergency, there should be space for movement of the crash trolley or any emergency equipment between the beds. So if you have them very close to each other, then that's going to hamper the emergency process. So you should have adequate spacing, good nursing staff, qualified physicians to look after the volunteers. Then you should have, because I think this is what I've covered, the pharmacy lab, and the volunteer housing area, the volunteer verification of the participation. So we used to give them ID cards. So every volunteer should have some sort of an identification, because many a times the volunteers replace each other. So that's not very advisable. And then a well-equipped ICU or emergency procedure area. Then when you go to the bioanalytical requirement, again, the bioanalytical lab, which can be within the unit or it may be in outsourced space. But the bioanalytical unit ideally should be standardized and regulated, and then there should be all validated equipment with strict SOPs which are in place. SOPs need to be there for clinical investigation aspect, for volunteer housing, and for everything right from the screening procedures till the volunteer discharge. Similarly, even the bioanalytical unit needs to have proper SOPs, again, which were lacking when we had gone for a couple of inspections. There were SOPs, but the people were not trained on the SOPs, so that's another issue. So there should be a training certificate for all the staff on the clinical side as well as the bioanalytical side. So the bioanalytical equipment, here we have the SOPs for method development, validated standardization, and so on. So if we don't follow the regulatory requirements, then we are always we've been in the news for the wrong thing. So that is the flip side of the whole story. So we need to take, precautions that we don't come into the news for the wrong things. And to oversee all this, we need to have a good quality assurance of the quality control unit. So the QA/QC systems with written SOPs, they need to monitor and oversee the whole procedure being conducted, whether it's being done in accordance with GCP, GLP, GMP, and applicable regulatory requirements. So this is something which is very important. So the QC system needs to take care of all this, especially the GCP part when the volunteers being housed. And the QA personnel, they should be independent and they should assist in quality control, including conducting and monitoring trials. So why we say it should be independent is if some of the one inspection we've seen that one of the clinical investigators, colleague or friend, they were actually doing the QA aspect. So that is not very advisable, because then it's not done the right way. So and then documentation needs to be there for a QA person. So monitoring should be done at that time when the studies are being conducted. Many a times the monitoring is done after the study is being conducted. So then there are chances that you may miss on certain aspects. So during the study, it should be done. And then even for the bioanalysis, because this has also been a topic of apprehension and debate. So bioanalysis, again, something important. And then performing reporting and pharmacokinetic statistical analysis also should be taken care of. Ensure that all the software systems and instruments are validated and the systems are in place. So this should be, again, software upgradation, and everything should be preferably done online with the audit trail so that everything can be tracked very efficiently. And then the quality management system should also have, the root, we should be able to do the root cause analysis tracking the trends and seeing the data integrity and whether it is, and if there is any issue, after they do the root cause analysis, they should do the CAPA or the corrective, appropriate corrective and prevention action should be taken. But one thing which we have seen is if the databases are not very well maintained for the volunteers, then there are chances of volunteers being involved in many clinical trials. So some systems should be set up at the individual unit level as to track the volunteers also. Then MOUs with any accredited laboratories should be there ideally, because we have seen that some of the times the sample for screening was sent to different labs. So each time you're sending to a different labs, there is again a chance that there's a lab to lab variation. So what may be normal in one lab may not be normal in another lab. So this was one thing which needs to be taken care of, and for which you should need to have an MOU detailing the process of the analysis also for those lab tests when you're actually screening the volunteers. So that was missing in some units. And independent ethics committee. So this was again one thing, the most of the stuff people had an in-house ethics committee saying it's independent ethics committee, but then monitoring was not being done on a regular basis, which again raises the cause for cause inspection by the regulators. So as per the regulations, we know it should be within the 50 kilometers radius of the study site. Then of course, bioanalytical lab we have discussed, and then there should be provision for emergency services, especially if you are doing with some drugs which you think are going to be problematic, the newer MABs and stuff like that. There should be some sort of a system to transport the patient to an emergency place if the local unit is not equipped properly with the emergency handling procedures. And that should have proper SOPs, which again were lacking in some organizations. Documental, archival, and retrieval. This is again very important. We have been talking of SOPs through all through, and SOPs, just having the SOPs is not fair enough. We should be trained, and then that should be used as per the SOPs. So documentation, we know if it's not documented, it did not happen as per the GCP guidelines. So everything needs to be documented and documented real time. So this was again lacking when we have visited some units, because patient came yesterday at 9 o'clock is not okay. If a patient has come at 9 o'clock, it should be documented the same day. So that is again going to be an audit finding. Then the archival room should be again totally access controlled, with the delegation of responsibility being given to the person who's going to actually have an access to the archival facility. It should be a fireproof, waterproof, termite-proof room with proper temperature, humidity control. And now since we are having most of the data in soft copies, or which is actually either some provision should be there for the hard disk or the pen drives, or wherever the data is being stored, there should be some SOPs, and then that should also have some sort of a system where you can take out the data. And then retention of the product. So it is, once the study is done, the documents and the products have to be retained. So there should be SOPs for that. The SOPs are something which is extremely important. And for retention of the product, we've seen that a couple of centers did not have a proper SOP, because you need to retain the product which was used with the test and the standard product 5 years after conduct of the study, or 1 year after expiry of the drug, whichever is later. So that is little important. So when you see the flow of events, you have the principal investigator who again has most of the time the protocol is given by the sponsor, but the protocol should be agreed upon by the investigator only. If they say that we agree to this protocol, the study should start. Then because it's approved by the ethics committee and the regulators, then only after that the consent is taken, the volunteers are screened. Then you have the flow continues till the study is completed. The volunteer is discharged and in good health. And then there should be ethics committee oversight throughout the study. So what are the reasons for cause inspection for bioequivalent studies? And especially when you go to the FDA website, they've enumerated very clearly, and most importantly, what I've seen was they have talked about data integrity and validity issue, which was there in about 60% of the inspections. So data is something extremely important, and validity of the data. So it should be acceptable in all aspects. Then only the study is going to be a successful study. Of course, the others are there, but the percentage is relatively lower. So most important, 60% is data integrity issues. So yeah, what are the challenges? And we'll try to finish a little faster. The challenges, first, let us take the infrastructure and manpower. You have very good SOPs, you have very good systems in place, but you need to have proper manpower and infrastructure. Infrastructure, a very good clinical pharmacology unit, having, as I discussed, the bed spaces between the beds, the environment, and then there are very clear-cut guidelines laid down by the FDA, WHO, and CDSCO on how to actually create the unit and what is the requirements for a unit. And then you should build a system such that, the volunteers, the second thing is the volunteer transport, as I already mentioned. If there is a crisis, there should be a system in place where you can immediately help the volunteers doing some immediate CPR procedures and then transfer the subject to the nearest ICU. So ideally, everything should be in the same floor so that you don't waste time. And then recruit qualified personnel to conduct BAB studies. So many a times you have seen the people looking after the BSBA studies not being doctors. So it's very difficult for them to handle if there is an ADR or an emergency. So ideally, the trained personnel should be there. And if you're doing phase 1 or any other BAB study with some drugs which are really critically known to cause adverse drug reactions, then you should have even an anesthetist. Ideally, like we used to have an anesthetist posted when we had such studies going on. And then organogram, which clearly defines the roles and responsibilities. So many times this is missing. That's what we have seen. So, then the blame game starts as to this is not my role and I wasn't informed. So if you have a clear-cut organogram and a delegation of responsibility log, then most of it can be actually taken care of. Equipment, the equipment needs to be actually validated, even including the BP apparatus. We have seen the ECG machine, they're not being calibrated and validated. So unless that if it's not calibrated properly, and if there's an expiry in the calibration, please redo the calibration, including the height, weight, everything which is being used, as well as analytical equipment needs to be calibrated and validated. And then there should be SOPs for operating, which again needs to be, people should need to be trained on that. Like if a nurse is performing the height and the weight, then you should have an SOP, and then she should be trained on taking care of all that. And then weekly and monthly maintenance of the equipment as per the requirement. And then what we have had a couple of instances in our own state where the volunteers participated in multiple clinical BAB studies, and then there were a lot of issues, and as one of the members in that committee. So what suggestion we had given is that it should be an Aadhaar-based, system for registration of the volunteers. So the moment you actually click on that Aadhaar number, then there should be some way like a red light or something glowing, which tell you the volunteer participated in the study within 3 months, because we know that at least 3 months should be there between participation of 2 studies. So that was something which we have suggested. So there should be some sort of a system in place where you can track that the volunteers have, not in multiple studies. Training and SOPs, this we've been, I've said a couple of times, there should be training on the SOPs to all the people involved in the studies. And then there should be an audit trail, especially for major operations. You should be able to find out who made the changes, when the changes were made, or how the changes were made, and everything should be, you should be able to track retrospectively what all happened. So that's an audit trail, and that's again going to be very helpful, especially for volunteer studies when there are issues. So have systems in place to handle medical emergency, which we have already discussed. And then there should be drills conducted. Like we used to do some mock exercises before starting the phase 1 clinical trial, because that was, I think we were one of the people to do first the IV formulation phase 1 also we have done. So there should be some sort of a training to given to all the staff. Data security, yes, this is something again very important and again a big challenge, because systems should be such that there is security, because access, which means that the data should have an access control. So even if anyone is opening, people should not be able to open the laptops or the place where you have data stored. It should be access controlled, and then there should be passwords. Again, there should be delegation of responsibility for who is going to have the passwords. The soft copy, especially the IT, should be very, very strong, and there should be separate servers which are going to store the data, and then they should be able to retrieve the data. You cannot store the data and then say the systems crashed, which was one center which had given us such an answer that the systems have crashed. There should be backup of the systems again, so that this doesn't happen. And then if there is an inspection or an audit, you are able to track it. So you should build systems for archival and retrieval, hard copies, soft copies, everything in the shortest possible time. This was again another issue, because they said it's in a place which is around 15 kilometers from their unit. So I think, if you are storing in such a place, then there should be some provision to get the data immediately when there is an audit, because many a times the audits are not informed prior. So. And partnerships and tie-ups, as we discussed, conduct audits with the labs before finalizing, and then choose the labs, and which is an agreement with the principals of the BAB centers, and then of course check into the CDSO registrations. So I think my time is getting over. So some points to take home when you set up a BAB center. It is very interesting, very challenging, but of course it is rewarding also when you do BAB studies, because that acts as a training for the the students, because once they leave the unit, then they may go and join some BAB centers as some directors or the head of the units. So that will be an experience and then exposure to them. And then focus on getting the training and the systems in place before applying for CDSO registration. Conduct mock drills to ensure that everyone is trained on the SOPs and adhere to the SOPs. Ensure that all equipments are calibrated and maintained, and then you should have a register where you're going to update it regularly, and keep the old calibrated logs also into one file, because that will again be a point of check when there is an audit. Ensure robust documentation, real-time documentation, and proper storage and archival of the documents, and a backup retrieval whenever it is required. So these are the references, and thank you for giving me the opportunity. And I would like to thank my student, Dr. Rupali, who's helped me in making these slides. So thanks a lot, and over to you, Shambhu.
Thank you, madam. That was a wonderful 360-degree coverage of the area of BAB studies, etc. And we covered everything from the requirements for the center itself, as well as the bioanalytical part, as well as data security and everything. So once again, thank you very much for sparing your valuable time. We will now go on to the last topic of this session. I think. Okay, so question. Yeah. Dr. Sandhya.
Yeah, yes. Thank you, madam. That was a very nice talk, saying everything about the BAB study. I have a query. For example, if a parent institute is having a branch which is in another city, more than 50 kilometers, can the parent institute have the ethics committee to monitor something which is happening in the branch hospital of that particular parent institute, which is more than 50 kilometers and in another city? Or should we have the ethics committee in the same hospital?
See that this 50 kilometers has been, topic of debate when, when we are forming the guidelines. Actually, what happens is 50 kilometers is not a hard and a fast rule. You can't measure that. So what we actually mean is, since the ethics committee members have to go and monitor. So if it's within 50 kilometers radius, that was a random number. It can be 60, it can be 40. So if it is within the 50 kilometers radius, then it's easy for them to go, because the ethics committee members again do have a 9 to 4 job. So apart from the job, if they have to go to a center which is around 100 kilometers, then it's going to be difficult. So that's an arbitrary number of 50. So let's say for monitoring whatever is convenient and comfortable to the ethics committee members, yes, within, if it's around 50, 60 kilometers, then they can travel up and down, then it's fair enough. Otherwise, it's always better to have another, ethics committee where it's going to monitor things. So that's it.
Okay, madam. Thank you, madam.
Thank you, madam.
Sinha, Swadhi.
You are audible.
Subhadeep, I think you're muted. You wanted to ask something?
Nice presentation. Just I want to know from you that in case of your BA sector, so there is so many components. So one of the most important components that is your analytical laboratory, and it should be approved. So if it is not approved, but the analysis of the drug is being done following the principles of GLP or NADA, so whether the data will be accepted or not.
Shambhu, can you repeat? It wasn't very audible.
Hello, madam.
Yeah.
Can I am audible? So the center, so there is so many components. So one of the most important components that is your analytical laboratory. So for this analytical laboratory, that should be approved by the GLP or NABL or appropriate authority. So if it is not approved, but the system is there, and if we follow the principles of GLP, so in that condition, the data will be accepted or not?
Normally, ideally, they're asking for a regulatory approval for the labs also. Otherwise, then the data may not be accepted if the labs are not approved by the regulators. And that was because there are chances of, the data integrity comes into place. So ideally, you should have an approval by the regulators for an analytical lab.
Because you know very well that it is very difficult to maintain this type of laboratory under government organization or institution. Okay, thank you.
Yeah, Professor Shantanu Tripathi for the final comment.
Hello, sir. This is Shantanu Tripathi. So let me share my experience as Dr. Mondal was asking regarding whether the analytical laboratory needs to be also approved. The answer is clear, yes. We recently had some attempt that the volunteer housing is in the hospital, unit, BAB unit. It has a volunteer housing and sample collection, dosing and then sample collection, and then its analysis. So analytical part is definitely difficult, and many a times the hospital that intends to start this center, they find it difficult to invest into a high-end laboratory. So we actually tried in Kolkata that the hospital agrees to do the volunteer housing and sample collection, etc., and transporting the samples to another facility, which is maybe 20 kilometers away, and there the analysis will be done. But then we are very clearly told by CDSCO that both these centers needs to be approved by them. And we actually went for the hospital will take a couple of years to develop their own laboratory. But then we got the response that in that case, again, you have to face the approval from the CDSCO. They will inspect, and under the same roof, whether we have the volunteer housing as well as the analytical laboratory. So this is one experience. So we are waiting for the same hospital to develop its own laboratory setup where the analytic analysis can be done under the same roof. This is one experience. The other is in this city in Kolkata. There is already one center which is running for a good number of years. And there, because of the logistic reasons, they have the voluntary housing in one place and maybe in another 500 meters away, half a kilometer away, there is the analytical laboratory. So whenever the CDSO inspection team comes, assessment team, they visit both these centers and try to see whether that is as per the requirement, the regulatory requirements. So it should be very clear that if you want to do BAB, it has both these two components. And the third component, of course, we haven't discussed about the ethics committee. The ethics committee could be an independent committee, or many a times the center itself has its own ethics committee, BAB center itself. But that center, even if it is within that unit, it also should maintain its autonomy and independence. So these are the three components of BAB center. I think you agree, Dr. Usha, what we just discussed. Over to you. Thank you.
Yes, sir, that's very correct, because now when the drug, when you're applying and the DCH is giving approval, they will say the clinical part is being done where and which lab is going to do the analysis. So even for clinical trials, the same thing they follow. So unless it is approved by them, then they don't give approval for even conducting of the study. So both need to be approved by the regulators, sir.
Thank you very much, madam. That was wonderful. We now go on to the last talk of this session, a very important topic, ethics in clinical research, neglected issues. And we have a change in speaker. We have Dr. Shreyashi Dasgupta from the School of Tropical Medicine in Kolkata to speak on this. Okay, Dr. Sinha. Yeah.
Yes, he has already unmuted himself. Sir, you may go ahead with your question, Dr. Sinha.
Yeah. No, I think partly it is answered regarding the analytical facility. I think what I wanted to know is that there are two types of lab facilities that need to be seen. One is the diagnostic lab, which is meant for the lab biochemistry and all that. That should be also accredited. And if this data needs to be submitted to the, generally for industrial BAB centers, you need even the central, what we call the central lab to be also have some accreditation. The bioanalytical lab actually need not be there in, many pharma companies, when they engage the centers, the academics, the medical center, college centers, they use that mainly for the clinical part. Because their bioanalytical methods have been already developed by the company, and they have they have the center for the CDSU with them. That is one part of the story. But the second part of the story, as yesterday also I was talking about, when the phase 1 centers, which have been approved recently by ICMR, which is also similar facility. There, when we develop the phase 1 center, especially to encourage the Indian new drug developer, the research institutes to develop new NCs, there I think the bioanalytical facilities are lacking. And none of these centers which have facility to begin with. So bioanalytical facility approvals understood, but it is more for BAB centers, it is not really required, because most of the BABs are done for regulatory purposes by the pharma companies, and they already have that approved centers with them. It was a comment more than a question. Question was also on the ethics committee. These phase 1 studies or bioequivalence studies, these are non-therapeutic in nature, primarily clinical pharmacology in nature. So is there any additional clinical pharmacologist that should be included in the committees governing, they often govern both BAB as well as phase trials, but especially the BABs and phase ones, they should they have a clinical pharmacologist on their board as an additional member study at least for these studies beyond the approved composition, or maybe add for an additional approval for this.
With Dr.
Anyone like as a guest they can come, because if the clinical pharmacologist is the basic scientist as per if that is being shown, then it is fair enough. But if you have a basic scientist and the clinical pharmacologist is called as expert, they can only visit, they can only give the comments, but they can't participate in the decision making if they're not part of the ethics committee. Because you can take their expert opinion, there is no doubt about that, but that should again be in your SOP.
Thank you. Thank you, Dr. Sinha, and thank you, Professor Usharani Pingali, madam, for this wonderful deliberation. And now we are requesting Professor Shantanu Munshi to kindly felicitate our chairperson because sir has another meeting, emergency meeting now. So Professor Subhankar Chowdhury, sir, kindly felicitate.
Now we start.
Good afternoon again. This is a momentous occasion for me to be sharing the platform with stalwarts like C. Adithan sir and Usharani ma'am. And I believe this topic was to be discussed by Dr. Urmila Thatte madam, who is one of the pioneers in research ethics in the country. And I shall make a humble attempt to cover some of these areas. And before I begin, I would like to acknowledge the inputs from my mentor, Professor S.K. Tripathi sir, and some of my seniors who have helped me in preparing this presentation. So what I will be speaking today is I'll try to dwell upon the neglected areas when it comes to research ethics in our country. So to discuss the same, I have thought of the whole thing as I have divided it into 4 perspectives. So I'll be looking at the neglected areas from the perspective of conduct of clinical research, from the perspective of an ethics committee, from the investigator's perspective, and from the site administration's perspective. So when we talk of research, or when we talk of ethics per se, it is basically the differentiation between what is right and what is wrong. But when we talk about right and wrong, there is a gray space in between where we actually are not sure which is the right way to go forward to. So coming to conduct of clinical research, if we look at the National Ethical Guidelines for Biomedical and Health Research involving human participants, the ICMR guideline, which was released in 2017. So therein, we find that when it talks about academic trials, especially for compensation related to research harm arising out of academic clinical trials, it says that research participants who suffer direct physical, psychological, social, legal, or economic harm as a result of their participation are entitled, after due assessment, to financial or other assistance to compensate them equitably for any temporary or permanent impairment or disability. So in this case, participants, in case of death, participants' dependents are entitled to financial compensation, And it only says that the research proposal should have an inbuilt provision for mitigating research-related harm. Now, when we look at compensation in the new drugs and clinical trial rules, when we talk about clinical trials with new for investigational new drugs, or even for BA/BE studies, there is a clear rule or clear guideline as to how to go about compensating the participants who suffer harm out of these research. How that compensation is to be calculated, what is the pathway, or what is the way in which such compensation is to be given to them, how the analysis, causality analysis is to be done. But when we come to academic trials, there is no clear guideline as to what the quantum of compensation should be, whether it should be aligned to that which a clinical trial for, participant in a clinical trial for a new drug is entitled to get, or whether because this is an academic clinical trial with a drug which is already established, which is already being used by other people in the market, can we say that they maybe are entitled to a lower quantum of compensation? There is no clear consensus on this. And this is one area in which we need further clarification or further guidelines or further inputs from the regulators. Now coming to standard of care. Now, when we talk of standard of care, if we look at the global picture of it, there is a wide disparity in when we talk about access to standard of care. Well, what is a standard of care in maybe a developed nation like the United States of America may not be accessible to the average population over here in India. So when we talk about a multinational trial or a global clinical trial, can we have a similar standard of care for all participants, whether they belong to a lower income or middle income country, such as ours, or when we talk about developed countries? And supposing even if the sponsor is willing to offer the standard of care as part of their clinical trial, what happens to the participant after the trial is over? Now, while the participant was a part of the clinical trial, he or she was getting the standard of care as due to him. But at the end of the trial, when the trial ends, the participant is no longer able to afford that standard of care. He was getting it because he was a part of the trial. What happens to that participant after it? Have we gone through that? Have we looked into the ethics of that part? Now, and in some cases, we do not have a clear consensus on what the gold standard is. What is the gold standard for standard of care, as to say, especially in oncology, there is no consensus. There is in some cases a lack of consensus among physicians on what the standard of care should be. As was being talked about by Dr. Shoivaldas yesterday, even in lifestyle intervention trials, we do not have a gold standard. We do not know what is the advocated standard of care for a particular lifestyle intervention. So this is also an area which needs further deliberation. A similar or related topic is a post-trial access. Now, for the sake of students who are here, post-trial access is when you have a new drug or an investigational new drug, which is being given to a trial subject as part of the trial. Now, after the trial is completed, the investigator feels that the participant would benefit out of this new investigation, out of this investigational new drug, and he or she should be provided this drug because he has shown a clear benefit out of it. Now, this can only be given if there is no other standard of care or no alternative treatment available for that particular condition. And there are other rules and regulations how we need to procure this post-trial access. The sponsor is actually responsible for providing the post-trial access, but is not liable for any adverse effects arising out of it. Now, who takes care of these adverse effects, even if they arise? Because the sponsor is clearly not liable. Is the investigator liable because he has vouched for the participant in this case? Also, for how long can this post-trial access be provided? For how long would a sponsor be willing to provide such a post-trial access, especially if we are talking about biologics? Now, in that case, because these are very costly drugs, so to say, so how long can this, can we almost force a sponsor to maybe provide the post-trial access? Do we have any clear-cut guidelines on that? And again, as I was saying, what happens to the trial subject after the trial ends? Suppose we have maybe for a simple condition, like say for diabetes, we have two drugs. We are doing a superiority trial and we have drug A and drug B. Drug A is the standard of care. Drug B is the new drug, investigational new drug. And at the end of the trial, we find that patients who were receiving drug B have improved significantly, or their glycemic parameters have improved significantly by use of this investigational drug. Now, at the end of the trial, can we ask the subjects to go back to maybe drug A, to which they were not responding? Or because we cannot expect the drug to come into the market immediately. There will be significant amount of time after which the drug will be available in the market. What about their medical care during that intervening period? And if at all that drug comes to the market, will the patient be able to afford that drug? Because most of the patients who participate in clinical trials in our country are from the lower socioeconomic class. So what happens to them later on? Next, coming to the informed consent process. Now, in spite of all the good clinical practice workshops, trainings, etc., can we truly say that the informed consent process in our country is an informed one? Do the subjects actually have the wherewithal to fully understand what they are getting into? Can we improvise this method further? Next is the topic of the term of deferred consent. Now, this was a term which came to the fore during the pandemic, because in many cases, we have patients who are not able to give consent at that point of time, but we have investigational drugs which the investigator feels that the patient may benefit out of. Even in case of terminally ill patients or end-of-life care also, the consent has to be deferred. We need to put that patient into maybe an investigational arm where we feel that the subject would benefit, but only after the subject regains consciousness can we take the consent from the subject. So we do not have any clear-cut guidelines on how to go about taking a deferred consent, who are the people or in which conditions we can take it, how we should take it, how we should document it. All of these are not available in the guidelines at present. There is a need to incorporate them because we never know when the next pandemic will strike us or when some other emergency comes up. Also in terminally ill or end-of-life care, in some cases, the patient is not able to decide for himself or herself. It is the patient's family members who decide. So does the patient at all wish to continue with a drug which will save his or her life? Or does the patient not want to take or not want to bear any more of the condition that he is in? We do not know. And this is probably another area where we can have more discussion on. Some other concerns, while we are talking of conduct of research, is especially in surgery, we have sham surgeries or sham procedures to account for the, to have a similarity in both the groups. So in one group, we are doing a surgery, other group, we are doing a sham surgery, so that there is adequate blinding, or the people, we have a comparability between the two groups. Now, can we truly assign or subject somebody to a surgery which that person does not require? I do not know how much this is being done nowadays, but this is also a thing where we should delve into. Now, there are some drug trials which have a lead-in group. I had come across a study protocol a few days back where they were trying to treat hepatitis C subject patients. Now, hepatitis C has a treatment as of now. Now, this was a phase 2 study where they wish to start a group on an investigational new drug, naive hepatitis C patients. And after a certain period of time, if they do not find virologic, if the patient does not respond adequately, they will not continue with the study anymore. They will terminate the study at that point of time. Now, these patients have enrolled themselves into the trial with an expectation that they will be cured of their condition. Or in the first place, when they came to the investigator, at that point of time also, they had an inherent wish to be cured of their condition. Now we have incorporated them into the trial, asked them to take a drug. At the end of the trial, we are saying that, no, we have not been able to cure you. Now you are left to yourself. Now you decide what treatment you are about to get. Now, is it not the responsibility of the investigator or the sponsor to ensure that such a subject gets the treatment which is already available? So we do not actually, these things are not discussed in the guidelines as of now. So I feel we need to incorporate these two. Now, again, washout periods in trials. We have crossover trials where we have subjects in arm A and arm B, and after they continue with a drug till some point of time, Then we have a washout period so that the effect of that drug is washed off, and then we cross them over to the opposite arms. Now, during this period of time, during this washout period of time, they are not on any therapy as such. So is that actually ethical? Next is decentralized clinical trials. This is coming up in a big way nowadays. And I feel as a country, we should also incorporate adequate guidelines as to how to go about conducting decentralized clinical trials. Because if we have to compete with other countries, this should be incorporated in our regulations also. Next, just a few points about the ethics committee. So we have several ethics committee over here, but this is something which is observed that in the review process of the ethics committee, the non-medical members usually are reluctant to participate, or they do not find themselves able to express their feelings or express their viewpoints as openly as the medical members are able to. So we need to give further impetus to the non-medical members so that their contribution to the ethics committee is also duly recognized. Reluctance to engage in continuing review process. So we have ethics committees, we have GCP certificates, but do we have continuing review process? Are we taking this as seriously as it should be? Are we continually reviewing the proposals that are submitted to us? After approval, do we go about actually looking into how those studies have progressed, whether they have actually published their results, how they have collected the data? So this overseeing, the ethics committee is supposed to oversee the entire research conduct. It is not just only about approving studies, but after approving, whatever role is should be conducted by the ethics committee, are they doing it actually? And do we have any other means to actually see whether these ethics committees are doing what they should be doing? Are they addressing the conflict of interest adequately? And is it being managed as it should be? And absence of continuous capacity building activities. So SOPs are updated, but and maybe these are even circulated to all the members, but adequate training sessions for SOPs, or maybe recognizing that newer guidelines or newer updates to the guidelines are coming up, and appraising the members about these developments. This is not being done on a regular basis, and I believe this should be looked into. Now, when we talk of investigators, we need a GCP certificate before we do any kind of a clinical research, but that gets confined to only having a documentation of a GCP training. So we are, most of the investigators have a general tendency to just mechanically comply with the minimum ethical standards that are required of them. They do not actually delve into the intricacies of these guidelines or the ethics related to research. So there should be some mechanism by which this can be further reinforced. And when we come to site administration, many a times we find that there is a lack of insight among the site administrators in terms of ethical conduct of clinical trials, ethics related regulations, guidelines, etc. Also, they are in most cases oblivious to, or they have a tendency to ignore their application to the trial subjects in respect to medical management of subjects when they report with any adverse reactions, etc. So this is just my penultimate slide. So I just wish to say that in lines of the famous ethicist Michael Josephson. So he had said that ethics is not about the way things are, it is about the way things ought to be. So taking a cue from this, I would just like to say that we should not be comfortable in the gray areas, but these are actually the areas in which we should work upon so that we can further refine the guidelines that are present in our country at the moment so that we can actually conduct good research. Thank you, sir.
Thank you, Dr. Shreyashi, for your nice presentation. Now the topic is open for discussion. 1 or 2 questions from the audience. So if there is no questions, so thank you, Dr. Shreyashi.
Thank you so much, sir.
So now we are going to conclude this symposium, clinical research and ethics. We had 3 speakers at this symposium. Dr. C. Adithan, who has nicely described the pharmacogenomics to support drug development research. Dr. Usha, She also discussed on BAB study center, their guidelines, etc., etc. And lastly, Dr. Shreyashi, she informed regarding the ethics in clinical research, and these three speakers nicely delivered their topic. So I am thankful. I thanks to all of you on behalf of the chairs, myself and Professor Subhankar Chowdhury. Thanks to the audience as well as the organizer to cooperate to organize this symposium. Thank you.
Thank you.
Thank you, sir. Thank you, Professor Usharani Pingali, madam. We miss your physical presence, but thank you for your lecture. So now may I request Dr. Shoibal Mukherjee, sir, to kindly felicitate our respected chair, Professor Tapan Mondal, sir. Also, may I request Dr. Shreyashi Dasgupta to please come. So now we'll have a lunch break, and following the lunch break, we'll have the concluding session, that is a clinical pharmacology in patient care. That session will be post lunch. So now I am requesting all the delegates to take the lunch and then please come back. And those who are having the poster, Professor, one evaluation already done. Now Professor Prabhakar Reddy sir will do the final round of evaluation. So after you take the lunch, then please be ready for that particular evaluation. Thank you. So I request our online participants to finish your lunch too, and you can. We are very sorry that we cannot have that services to send you the lunch box, but after you come, we'll come back after our lunch. Then again we'll have some academic fest.
Thank you.
So I think Dr. Bhaskar is not there. So I will request, but it is not good, sir. So we need more physical participation. So I think for that we need to promote physical participation. We cannot provide the lunch online. Thank you once again, madam. Thank you all the respected people who are there. Thank you once again.
Yeah, thank you, Shambhu. Thank you.
So we'll be back at 2:15. So I am requesting all the delegates to please join us at 2:15.
ম্যাডাম আপনার ওখানে ওদের একজন করে নিয়ে ঢুকিয়ে নি পরীক্ষা দেওয়ার সাথে দেওয়া যাবে না এবার পরীক্ষা দেবে তাহলে এক্সাম তাতে কি হয়েছে তারা পরীক্ষা সেটাই তো একটা কারণ ফিরে আসতে হবে আবার আর কি করে ফিরে আসবে 3 বছর বন্ধ এই দুটোতেই করবে নয় আসামটা আরো ভালো কিছু হয়ে গেল আজ করে থাকবে নাহলে সংসারে থাকবে বলুন বলুন পরীক্ষা দিতে বলছি তো বললাম যে দায়িত্ব কারণ আমি তো নিজেই নিজেকে ডাকতে আচ্ছা আমার পরে শুরু করে দিয়ে আস্তে আস্তে
স্যার বলবেন তারপরে না তারপরে
Welcome back to all the delegates. We shall begin with the last symposium. This is the symposium on clinical pharmacology and patient care optimization. There are a total of 4 lectures of 15 minutes each. And to chair this session, I request Dr. Tapas Bandopadhay sir to come onto the dais and take the chair. Also, I would like to request Dr. Shreyashi Mukherjee sir to please accompany him as a co-chair for this session. Before we begin with the sessions, I would request Dr. Shreyashi Mukherjee sir to please felicitate Dr. Tapas Bandopadhay sir. Request the chairpersons to kindly introduce the next speaker.
Yes. So this is the last session of this 3-day long marathon CME program. And this session is on clinical pharmacology and patient care optimization. There are 4 speakers. And may we introduce Dr. Shantanu Kumar Tripathi, who is no introduction to our August gathering. He will be speaking on drug-induced disorders, followed by 3 other speakers. That will be again the reiterated by our co-chair, Dr. Mukherjee, later on. Thank you so much. Sir.
Good afternoon. Welcome to the last session of this conference, 3-day conference. And in this, the theme is, what is the sub-theme of this thing? Drug-induced problems. No, not conference, this session. Patient care, clinical pharmacology and patient care. And there are, I think, 3 or 4 lectures. The first one is this. My talk is actually drug-induced disorders. I consider drug-induced disorder, if you accept this as a disorder, as the name suggests, it's a disease. Now, whenever a patient comes to a doctor, the doctor is supposed to diagnose his disease and then plan the treatment and prescribe. And for diagnosing the disease, there are universally recognized and accepted strategies that you listen to the patient, then you examine depending on the symptomatology. Of course, it is overall examination, but then you focus on particular system, the system that might be otherwise perhaps been primarily involved will get more attention. And then you do the clinical examination, then you do some laboratory investigations. And initially you give a provisional diagnosis. And even for reaching a provisional diagnosis, you also consider a number of differential diagnoses. And then you order some laboratory tests. And as the laboratory test reports come, based on that, probably you go for a final diagnosis. That's the way we go. And that's true for any and all diseases. If I'm not wrong, we have our internal medicine expert also here, professor of medicine. So, but then any disease you can think of, this is the pathway. And if you accept there is a disease called drug-induced disease, or rather a constellation of diseases, depending on its manifestation, again, it could be affecting the central nervous system or GI system or cardiovascular system or whatever. But then as a group, we can call it drug-induced disorders, that also will require diagnosis. And the workup of that patient will not be any different. There also you have to think of, you have to suspect first. And what you are suspecting, in order to cleanse that, or in order to justify whether the suspicion is correct or not, you have to again listen to the patient, take his history, and then again, depending on the symptomatology, we'll go for examination, clinical examination, maybe with a focus to particular system, which might be affected most. And then again, through the same strategy, again, you have to think of differential diagnosis. It may not be drug-induced. My point is, my stand is, any patient coming up with any problem to any doctor, can he ignore the possibility of a drug-induced disorder as a differential diagnosis? So truly speaking, drug-induced disorder is a common differential diagnosis in all medical consultations. So truly speaking, every doctor is ruling out drug-induced disorder in order to finally reach out any other diagnosis other than drug-induced disorder. And in order to rule out again, he has to go for in a stepwise manner. So it is quite possible, it is very, very unlikely that a doctor coming to a patient coming to a doctor seeking care, at that point of time, the patient is not receiving any drug whatsoever. It is quite unlikely. In most of the situations you will find, at least I think, again, it depends on the context, the age of the patient, etc. Particularly if you think of an elderly patient, it is almost 99% unlikelihood that the old man is not receiving any drug whatsoever. So if he is already receiving a medication, then you have to also definitely consider whether the medication is actually the culprit for which the patient or this person who has come and consulting me, it is his problems, whatever are the problems, it's not really associated with in any way with this medication that he is taking. But then I have a feeling, I have a belief that perhaps drug-induced disease is an orphan differential diagnosis, if I am permitted to say so. It's not possibly receives the attention it deserves. So it can be a debatable statement. This can be debated upon, but then I actually would like to provoke this debate. What are drug-induced disorders? They refer to conditions or symptoms that are caused or triggered by medications. As simple as that. It can range from very mild side effect to severe and life-threatening reactions. Often a challenge in the context of comorbidities, polypharmacy, and complex regimens. The more the number of medications, the more it will be difficult to clench your diagnosis, but the more likelihood it would be that it could be a drug-induced disorder. So it increases exponentially. 1 drug, 2 drugs, 3 drugs, 4 drugs, as you increase the number, polypharmacy. So the chances of this ultimate diagnosis being drug-induced disorder increases for obvious reasons. Most of us are here are pharmacologists or clinical pharmacologists. Often it is a neglected differential diagnosis. Diagnosis and treatment of drug-induced disorders require a thorough understanding of patient's medical history, medication history, and relevant workup. What I am saying might be very simplistic and very elementary, but many times the elementary issues also escape our attention. So there is a need for emphasizing and re-emphasizing the elementary issues. Diagnosing a drug-induced disorder, we should learn to suspect. Always suspect and rule out. So any patient who comes with any problem, remember, a common DD is differential diagnosis is this, and you have to rule out that and think of other etiologies. History and assessment of the symptom is very important. And for that, look at the patient, talk to the patient, listen to the patient, and identify any symptom that cannot be explained by the existing disease. If the patient you're thinking that the patient has heart failure, can the heart failure be caused by any drug that the patient is using for the last few months or a couple of years? Think about that. Otherwise, yes, heart failure is diagnosed, but what is the cause behind that heart failure? Or any other thing, a renal impairment. Okay. Think of whether there could be any medication that the patient is receiving for on a long-term basis could be implicated for this problem. Otherwise, it could be, yes, you are trying to actually correct the problem that the patient is facing without looking at the trigger factor or the etiology or the causality behind it. Appreciate and understand patient's existing condition and the prescribed medicines, what medicines are already prescribed and the patient is probably complying with. And here is also another area, that adherence issue. On one hand, we say that adherence is always a problem, but at the time when we are trying to look at a pharmacovigilance exercise, an adverse reaction monitoring exercise, there we assume probably that whatever prescription has been made, everybody is very honestly complying with that. May not be necessarily so. Okay. If compliance is a problem, you have to also think of that problem while we are actually working up on a pharmacovigilance exercise, an ADR monitoring, suspected adverse drug event monitoring. Appreciate and understand patient's condition and prescribe medications, comorbidities, and concomitant medications, allergies, including drug allergy, etc. And there are many other factors, not only the drugs, there are other factors, lifestyle factors like alcohol, like other things also we have to consider. Examination is definitely a very important part of such workup. Identify any visible signs of already known drug-induced disorders. Focused examination of the affected system would be also required. And then if we wish to eliminate or rule out the possibility of drug being implicated or medication being implicated for this, then we need to examine, it is already well accepted steps in an individual case safety monitoring. And there you need to examine temporality, determine the timing of the onset of symptoms in relation to the initiation of the drug. Some drug-induced disorders may develop shortly after starting a medication, while others might take longer to manifest. The ones which are shortly after, it is easier to suspect. The ones which are causing a delayed response, it becomes difficult to really suspect. But you have to keep in mind it is also possible. Lab tests, routine or specialized tests to evaluate the vital organ function on one hand, and then the blood cell counts, etc. And specialized tests like skin patch testing, allergen testing. Some of these have been discussed on the first day. The imaging studies might they also be necessary to make an accurate diagnosis. Yes, we need to try the challenge. Here lies the question. In fact, why we have kept it here, because as we have stated, it is a relatively neglected area. We are trying to also explore whether clinical pharmacologists, they can be a part of, they can be considered as an important stakeholder in this management of these kind of patients. Any patient who might be suspected to be suffering from a drug-induced problem. So there, when you talk of de-challenge, who can go for de-challenge? Anybody, the person who has prescribed. Here lies another moot question. We often are discussing for the last 3 days and also before that, that whether a clinical pharmacologist, if we consider him as an expert in this area, can in his own merit and in his own right intervene in a patient whom an internal medicine man is otherwise given a prescription. And if it is done in the best interest of the patient, whether the primary prescriber, how he would take it. These are the moot questions. Most of the time, we, the clinical pharmacists, they feel, how can I change his prescription? Do you ever think of when a prescription written by an internal medicine specialist, he goes to a neurologist, and neurologist, does he think twice to make any change for a neurological problem which has been otherwise treated by an internal medicine consultant, or for that matter, a cardiologist? So why is it we are thinking, why we are so not having enough confidence that this is our area, critical skill area, a adverse drug-drug interaction problem. If it is very clear in front of our eyes, why can we not make a comment? If we feel very shy about it, at least we will write a comment and request the patient to go and to his primary prescriber and show this. So trying de-challenge is again an issue, okay, which can stimulate debate. Who is going to do the de-challenge? Otherwise, in pharmacovigilance exercise, we have always said that the pharmacovigilance officer or pharmacovigilance personnel is not supposed to do de-challenge. If de-challenge is done by the primary physician, what is the implication of that de-challenge? What is the outcome of this de-challenge? The pharmacovigilance personnel will follow that. That means pharmacovigilance expert or pharmacovigilance professional, he is rather a passive kind of person who will look at the outcome and try to deduce rather than doing any active intervention. But here, what we are discussing, I would be rather expecting a trained clinical pharmacologist will have the confidence and courage to do the de-challenge, provided he is convinced, if I don't do the de-challenge and ask the patient to go to the primary prescriber, the delay in this is going to otherwise cause damage to the patient. And primarily we are doctors. Ethically also, we are not supposed to do this. If we feel this is not going to be in the best interest of the patient, we definitely have the authority to do de-challenge and also mention there why you have done that. I agree that we should not have, we also have a professional, okay, obligation, co-professional respect But at the same time, if we can prove your point that in the best interest of the patient, it has been done, and this is by no way, okay, to show any disrespect to the primary prescriber, I think there should not be much of a problem. This is unnecessarily, we are taking this a little too personal into this. So trying de-challenge and re-challenge, seeing if the symptoms improve with temporary discontinuation of the suspect medicine and then reappear before reappear, if at all it is ethically possible. Many a times re-challenge might not be acceptable, again in the interest of the patient. But in certain situations like in TB management, etc., there re-challenge is often done, particularly when you talk of the hepatotoxicity issues of most of the anti-TB agents. Pharmacological plausibility is again another area where a clinical pharmacologist has a greater strength and can check if the suspect drug is already known to cause the same problem. So that again goes in favor of the causality. Alternative etiology again has to be ruled out if we want to establish that it is because of the drug. Pharmacological plausibility and alternative etiology means consider if the problem can be explained by the existing disease or any other risk factors. So that is a negative attribute, and if it is actually explained by existing disease, then the possibility of drug induced becomes less. And finally, as a clinical pharmacologist, we have an additional obligation. Of course, we are expecting that any physician will do that, but in reality, most of the time that is not happening. But if you are a clinical pharmacologist and trying to also serve your patient through clinical pharmacological consultation, reporting to the appropriate authority, in this case, a pharmacovigilance program, that also becomes our obligation. So, treatment, coming to the treatment of the drug-induced disorder, once we have diagnosed, now can we treat? My question is, my argument is, why not? So long it is within your knowledge domain, within your comfort zone. If it is otherwise has affected the heart, or if it has affected the kidney or the GI system or the liver, and if you feel that it has to be a consultation or referral to a hepatologist or a cardiologist should be done, do that. But that doesn't mean that you cannot treat. Okay, you can refer the patient to this thing. This is drug induced, that much I have done, that diagnosis I have done. But for the rest of the treatment, I'm referring the patient to the cardiologist or the neurologist or whosoever, depending on what is the manifestation. So consider if the drug requires tapering to prevent withdrawal or rebound effects. So this is again, whether it will have the withdrawal rebound effects and how the tapering should be done. Here also the clinical pharmacological expertise and wisdom would be otherwise, I suppose, welcome by our clinical colleagues, other clinical colleagues. Symptom management is also a part of this treatment regimen, and depending on the severity and nature of the drug-induced disorder, symptom management could involve medications to alleviate pain or inflammation or allergy or any other symptom. Supportive care is also important could be crucial for some drug-induced disorders, involving measures like rest, hydration, monitoring vital signs. And for all these, of course, we have discussed also that if necessary, if there are some tweaking in the curriculum is to be made, it has to be made. If we feel with the given kind of training, we are not very confident to also provide this clinical care because of our deficiency in our current training program, we have to change that. We have to do that. But then this, hopefully, if we feel that we are enough trained, we should be able to do this. Substitution of the medication. If one medication is causing this, whether you are substituting with another medication of the same group or if you are going to the other group, and whether by substituting the medicine, you can really avoid the primary problem, the drug-induced problem, that also a clinical pharmacologist is a better person to suggest that. And clinical pharmacologist can provide that advisory or consultative service or referrals, consultation or referral advice to his clinical colleague, or he can just do that in the prescription. So discontinuation of the offending drug is not possible due to essential treatment. Consider substituting the medication with a safer alternative. And the last one is important. So follow-up is essential whenever you are managing such a patient, monitoring, close monitoring. After discontinuation of the offending drug, monitor the patient's progress closely, follow-up appointments, and additional tests may be necessary to ensure that the symptoms are improving and to address any lingering effects. And secondly, of course, What is this follow on, follow up, monitoring, and then follow on? By follow on, I wanted to mean that also give a report or give a kind of card to the patient, particularly in case of allergy. Mention that and ask the patient whenever he visits any other doctor, he should carry this card. If he is really allergic to a particular drug and you have identified that, so that should be given to the patient. Okay. Or if even if it is not allergy, even if there is a adverse drug-drug interaction, you can mention that this patient has shown already this. So if he carries a card and that card next time when he visits his cardiologist or his neurologist, he also shows that card along with other prescriptions. So that can also help him. That can also act as an alarm or an alert to the next prescriber who will possibly take a little more caution, exercise a little more caution. So management of drug-induced disorder should be individualized based on specific circumstances of each patient. It's important to consult a qualified clinical pharmacologist or an informed pharmacologist. I give emphasis on this adjective, informed pharmacologist. Not necessarily always we have to be a clinical pharmacologist probably, because truly speaking, we do not have enough clinical pharmacologists in the country. Altogether, we might be having 120 plus. While if we try to champion this concept or this strategy, again, it can boomerang that you are telling all this, but where are the people? Okay, they are not visible. How many clinical pharmacologists are there? But what we want is not necessarily a trained clinical pharmacologist has to do all by himself. He can train pharmacologists, he can train even pharmacists. But then again, you have to supervise. The pharmacists they are not authorized to do prescribing. So you can have a team of pharmacists, clinical pharmacists who can help you, support you, okay, provide the necessary assistance, and then you get into prescribing business. It's important to consult a qualified clinical pharmacologist or an informed pharmacologist for proper diagnosis and treatment. And if you suspect you are experiencing this, actually is addressed to the patient. There was also a question whether the clinical pharmacologist, when he is acting as a consultant clinical pharmacologist, he will only expect referred patients to him, or he can also expect directly patient will come. Today, it may appear a little queer that directly patient will be coming to a clinical pharmacologist. So, but then hopefully in coming years, if we can position ourselves properly, if we do promote it, if we project ourselves properly, publicize it, why not? Educated patients, if they suspect it could be because of drug, directly they will come to the clinical pharmacologist. That's my dream. I feel that in near future, maybe 5 or 7 years or 10 years from now, there will be people directly coming to a clinical pharmacologist seeking consultation. Is it because of any problem with my drugs? Thank you very much. Iatrogenic illness, that was the last one. And this is how to approach. There are some this is also the same way, like if we call them iatrogenic, then also this part also has been missed out. That clinical pharmacologist can actually do that, preventing further this thing. How can you prevent iatrogenic disease or drug-induced disease? For that, the kind of awareness recognition that is to be done, communication, reporting, and learning from errors. Medication error is another area, which again is in the domain of clinical pharmacologists, and multidisciplinary approach is to be emphasized. Individualized care is to be emphasized. Risk-benefit assessment is a domain of clinical pharmacologists. Regular monitoring, patient empowerment, and continuous education. That's it. Overall, a proactive and patient-centered approach to healthcare combined with a commitment to safety and continuous improvement is essential for preventing and managing iatrogenic diseases or drug-induced disorders effectively. Thank you very much.
Thank you, sir. Thank you for enlightening us about a very important and indispensable topic, that is drug-induced disorder. At this juncture, I would like to thank Dr. Sambo, the organizing secretary of this mega conference, and organizing chairperson, Dr. Santanu Kumar Tripathi. My heartfelt gratitude and thanks for allowing me to chair this session. I have a medical board. I am attached to this hospital, so I have to leave by 2:40. I take the permission of my co-chair. So I'll be there for another 10-15 minutes. I hand over. Okay. Okay. Okay.
I absolutely agree with you, sir, because sometimes we are actually in a dilemma and we need support from a person who is expertise in this field. And there is no denying the fact that internal medicine people are concerned with so many things, but we are actually incomplete without help of other subspecialties, super specialties. And in this particular topic, this drug-induced disorder, what you have said, I fully agree. And like me, I think that everyone who is here will fully agree that a day will come that the patient or the individual will come directly to the pharmacologist, clinical pharmacologist, and there is no shame on the part of the internal medicine, because that will actually, our goal is unified. The goal is same, to improve the quality of patient's life.
About the medico-legal part.
Yes, yes, sir. That, yes, right. Yes, 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 yes. This is very important. Yes, yes, yes. Responsibility is, yes. Yes, yes, sir. Yes. 100%, because yes, and particularly this is important in view of de-challenge and re-challenge. That is the most important part. We face in day-to-day practice, that when to actually, how to counsel the patient, and when we get support from our own colleagues, particularly the clinical pharmacologist, or sometimes we get the help of microbiologist in case of infections. So that boosts up the moral of the patient also, as well as the physician. That is what is important. Thank you, sir. I hand over the mic to our co-chair.
Thank you. I actually, much appreciated this last presentation, particularly the approach of looking at drug-induced disease from the point of view of a disease. And you have to follow the same procedure as you would do for any other disease. Now, in a clinical pharmacology consultation, I think that is no longer a differential diagnosis. When the patient has come to you for a clinical pharmacology consultation, then we are taking it for granted that that person is a complex therapeutic, in a complex therapeutic situation. He has got multiple diseases. He probably is a subject of polypharmacy and whatever other conditions he might have, a drug-induced condition. Exactly. A drug-induced condition is quite likely. So I think when clinical pharmacology consultation is happening, that needs to be the first focus to rule that out first of all. And then maybe we can think of any other things, but quite right. So thank you so much, Dr. Tripathi. We come to the next presentation, which is by Dr. Shantanu Munshi, addressing adherence in chronic patient care. Dr. Munshi is, I understand, heading the Department of Clinical Pharmacology at School of Tropical Medicine. Please take the dais, Dr. Munshi, and we look forward to your presentation.
Thank you. Thank you so much, Dr. Shoibal Mukhopadhyay. It's a privilege for me to present immediately after my teacher, Professor Tripathi, who is a doyen of clinical pharmacology, and it's a really challenging moment for me. Okay. We all know this issue of medication adherence, and it's so very important, and the clinician, they face a lot of challenge because of this issue, and it contributes to a great extent to increase in the healthcare cost, not only increase in the healthcare cost, and it reduces the quality of life of the patients. It can also bring about a lot of health issues as well as treatment failures. And in Western world, if we see every 100 prescriptions, only 25 to 30 prescriptions are followed properly. So there lies the challenge. So it's a very common day-to-day problem we need to understand as a pharmacologist and clinical pharmacologist. And fortunately, nowadays, we have a lot of tools. And if we can use those tools, and there are a lot of softwares also, software-based applications. And if we use them, it helps in treating this problem, reducing this problem of non-adherence and converting them to adherence. There are several factors for non-adherence, and we need to understand these barriers to adherence, like cost of the medications, like incomplete patient education, like limited health literacy for the patient, as well as forgetfulness, because elderly patients, they have cognitive challenges. So those issues have to be identified, and individually they have to be dealt with. And there lies the role of the clinical pharmacologist to get into that and identify it and solve this issue. So what should be the correct approach? Approach should be that not to go into it in a general way, rather based on the barriers. Try to find the specific barriers which are happening for that patient and individualize your approach, and thereby you can overcome this non-adherence issue. No, it's not changing it somehow. Yeah, it changed this one. Now you can change it like this. Okay. Yeah, fine. Now coming to a case, if we discuss this patient case, it will be very easy. Mr. Avery is a 62-year-old man who has elevated blood sugar since the age 40. He has been encouraged to maintain a healthy weight and decrease carbohydrate sugar intake. However, during his last clinician's appointment, his A1C was 9. So there has been a bit of discrepancy about what the patient is saying and what the results are showing up. So definitely, if you see the medication chart, that you find that there is poor compliance. He has arrived for his first appointment with you. And how do you accomplish in this session? So what we need to ask to understand that what are the behaviors do you want to address? The patient's behavior to medications, and whether they are modifiable factors that may be impacting patient behavior, and whether the health behavior strategy, which particular strategy you want to apply for this case. Now, to understand this situation, that diabetic patient is not only suffering from elevated blood sugar, but he also has a host of other problems like hypertension, lack of activity, raised BMI, and the patient is a smoker. Associated to that, he is suffering from depression, and there are psychosocial stress which are also involving. And all these factors may, lead to heart disease, cardiovascular problems. So where do we start and how do we start? That's the question. So WHO defines adherence as extent to which person's behavior, taking medication, following a diet, or making a healthy lifestyle challenges correspond with a agreed upon recommendation from the healthcare provider. And our Agency for Healthcare Research and Quality defines medication adherence more specifically. It says that the patient's conformation or conformance with the provider's recommendation in respect to timing, dosage, frequency of medication taking during the prescribed length of time. So this is a more comprehensive kind of definition. And basically, we need to understand that drugs don't work in patients who don't take them. So adherence is so very important, and you have to ensure that for every patient to get the outcome, desired outcome. So if we go into this medication adherence statistics, you'll find that is very interesting. Approximately what is the percentage of prescription which are never picked up from the pharmacy? Any idea? 20 to 30% of the prescriptions are not picked up from the pharmacy. And this is the Western data. This is the Western data, US data. 50% of the medication for chronic disease are not taken as prescribed. An estimated 10% of the hospitalization in older adults are caused due to medication non-adherence. And over 300 billion avoidable healthcare cost has been attributed to non-adherence in US annually. There are several studies, and it has of 1,705 patients with diabetes and hyperlipidemia, and showed that the adherence has decreased the all-cause medical cost by 15%. So there lies the importance of implementing medication adherence, and how to go about it is our challenge. The problem of non-adherence, there is clinical outcome related problems, like it causes poor therapeutic outcome, the disease can progress further, and also the quality of life will be decreased. And there are economic outcomes also. There will be increased cost to the healthcare system, increased amount of hospitalization, and also the frequency of emergency department visits will increase, and physicians visits. There will be loss of productivity also. So what are the reasons for common reasons for non-adherence? The first is, we know the common one is the patient complains about the side effects, concern about side effects. Next, we have another is there any efficacy to be expected if I take these medications? So there is a doubt in the patient's mind regarding the efficacy, or whether their need is there, actual need for treatment is there. Next is your cost. If the cost is high, automatically the adherence will be an issue. So we need to understand the patient's ability to procure the drugs and consume them effectively. And forgetfulness is, yes, that's another common issue for non-adherence. And we need to tackle all this along with lack of support, social support, impaired cognition, low health medication literacy, as well as if the patient does not able to follow the instructions. So there is need for better physician versus patient's interaction. And sometimes, the patient pill burden is so complex, you giving 4 to 6 times daily, and in the middle of the night, some tablets have to be taken. So those are real challenges. Also, as a physician, as a pharmacologist, we can look into this adherence problem from outside, and we can predict how much the treatment will be adherent to by looking into the organizational context, like whether the patient is under insurance, so that the cost will not be a limiting factor, or whether the patient has, this individual problems of the patients. And we have this social support is also very important to provide backup or reminder kind of things, whether the patient is taking the medication properly. And sometimes patients require some sort of encouragement from their family members, and who call them up and inquire whether the medications have been taken properly or not, because these are chronic disease and they have to continue their treatment for a pretty long time. So that is important. And we should also understand the patient's belief, attitudes, and personality before prescribing them the drugs, so that will also predict the adherence. So what is the strategy for this assessment? We have certain tools. We need to understand this self-report of the patients. And also we have this apps and other devices which will tell us whether the patient have been regular with their medicines or not. And very important, lab values will also reflect whether there has been compliance to the treatment or not. And so how do we ask the patient about adherence? Most people forget sometimes, but how often do you forget to take your medicines? So that we are giving that being a human, we can make an error, and it is not very out of the box to be forget taking medicines. But how many times you are forgetting? And if you feel better, are you stopping to take the medicine? Or if you are feeling worse, do you sometimes stop taking your medicines? These questions will give you the feedback whether the patient is adherent or not. And self-monitoring, you have this medication log sheet where individual drugs, name of the drugs are mentioned 1, 2, 3, 4, and how many times they are supposed to take, and if they are stopping, what is the reason, and all these things. If any side effect, they write it down, and you get a feedback from that also. Along with that, if you see this, there is this apps are given. These apps are usually available there also. We have our Indian apps, which are very useful, and if you can use it, it will be very useful. They are very useful. And we must also look into the objective data, that like exactly after the treatment, suppose you're giving drug for reducing blood pressure. If you check the BP, whether the BP has been under control or not, whether the sugar has come down or not, or whether the body weight is controlled or not. Along with, you have these apps which give you objective recordings. So how do we confront the patient? The patient was telling that he has been trying to maintain a good diet and a good exercise plan, and has been compliant with the medications. But the patient now admits that he has been watching his diet and monitoring his blood glucose, more vegetable, fewer desserts. I have been making a lot of changes, but my blood sugar, it's been below 150 for most of the time. But the results of A1C tells that it is 8, which indicates poor control. And he has also left his glucometer at home. That is conflicting. And so you now have to review the data and what do you do? What do you believe? And you have to confront him with this conflicting data. And later on, he confesses that, okay, maybe I have been taking my I haven't been taking my medications as I should have. And I've been eating too much of ice creams in the evening. And he comes with this confession, and then you have to handle that as well. So these are the very interesting situations, and this is how you approach in a patient who are less adherent. And there are evidence-based approaches where 5 main points are: you have to educate your patients when you're prescribing these chronic medications and the importance of this medication, the benefits, and what is to expect during the treatment, whether there is some common adverse effects, whether they check, how they monitor. Because after all, these are patient-oriented. They have to take responsibility. You have to motivate the patients. Okay. Another is there are specific barriers, and you have to identify with the barriers and give specific management for that. And you have to help the patient take medicine as a habit. And it is better if the patient takes during the breakfast time, during the morning period, and along with a common routine during breakfast, before breakfast, or where after brushing your teeth, things like that. That is how they will, adhere to that treatment. And motivational interview where, you engage the patient in a talk and give a positive affirmations and try to plan out a change in behavior and implement that. And that is very challenging. And what you intend to say is that if you follow this treatment, will it be good for you or will it be bad for you? And if you don't follow this treatment, whether that is going to be good or bad. And this is the decision balance the patient needs to understand. And this will help in changing their behavior. And there might be specific barriers to adherence. Others are there, like some patients are phobic. They do not want this insulin pricks. So then you have to tell them that what is the benefit and how to go about it if they don't take their insulin regularly. So there lies the challenge. So those behavioral change issues has to be dealt with, and somebody has to help there also.
Professor Munshi, how many slides do you have?
I have 2 more.
Can you just, I'll just ask your permission. My co-chair has to leave for a very urgent meeting. We want to felicitate him before he goes, and then we'll continue with your presentation. Already felicitated? No. Okay. Yeah, you got it. So thank you so much for being here and being my co-chair.
Thank you, sir.
Professor Munshi, you can please continue.
Yeah. Yeah. So we have to address the specific barriers, and like if the patient has phobias to needles or to taking pills, and how to overcome them and how to help remind us set reminders so that they do not forget to take the medicines in time. And there are several smartphone applications which are available. We can easily download and use them. And they have been designed for various kind of treatments, and they give you notifications, and also they have time zone arrangement. If you are traveling, it can be taken care of, all those time zones. And even the family members are also alerted if you forget 1 or 2 doses. So another important thing is self-management training, where the patient is rewarded if he does the things properly. And if he doesn't do properly, then he has to be again taken up and dealt with accordingly, giving him the advices and behavioral changes, looking at the barriers, specific barriers. So what is essentially meant here, that you require reinforcement to improve the behavior and improve the adherence, medication adherence. So I just mentioned that it's a better idea that you try to take the medications along with the existing habit, like when with breakfast or brushing your teeth, AM, PM, or before going to bed. That will help you remember the exact timing of the medications. And it is a good idea that if you forget to take the medicine suppose at home, you carry your medication in the purse. Whenever you remember, you take it. And even you can keep it in the car for a momentary periods, limited period, because there is again, the medicines are temperature sensitive and they might get spoiled after a certain period of time. And always try to encourage the social support, like friends and family, to remind the patients about the medications. And it's a good idea to connect adherence to values and meanings, invite patient to reflect upon why do you want to improve how to take your medicines, and how will improving your use of medicine impact your life. If the patient understands this will improve their behavior regarding the medications and their adherence to medications. So there is something called patient brochure, where we have all these things written down, and every institution should have them, and they can be shared, especially with chronic medication usage patients. And we can also take help of this pill box and other organizers, pill organizers, alums like this, that will also help in overcoming the non-adherence barriers. There is something else known as this electronic health record template, where we can also implement this adherence portion, that the patient is using a pill box, or whether a patient is using or not a pill box, or the patient is taking how many times a day, frequency of the missed dose of any medications per week, like that. And what are the common barriers he or she is facing regarding this adherence, and how to improve this adherence, whether the help of family and others are required or not. And accordingly, we can also plan our intervention and follow it up so that the patient is benefited with a proper health outcome as desired by his physician. So there is something also known as, after the patient leaves the consultation, after visit summary template, where the patient came for this and we talked about this, and these are the areas where we suggested some help is required and how to go about it, so that next visit, this can be monitored, and these areas, how it has improved, we can look into it. So this is all the structured practice, and we practice these activities. And we sometimes we can do a role play also. The one patient becomes the patient, one person becomes the patient, other the provider or the doctor, and they play among themselves how to take the medicine, how to improve, what are the challenges they are facing, the barriers they are facing in following the instructions, and how to go about it. And this will be observed by other real patients, and they will understand what are the issues and how to improve medication adherence. So these are the issues where the patient doctors face, that I hate taking pills, and it seems every time I come to the doctor, I get more pills. These are the common situations where the doctors face these questions, and doctor has to re-emphasize, refocus that the medicines are important, and how to go about to reduce the pill burden, how to patient understand that these are very important for his treatment. And also the issue of I feel worse than before when I started. So there lies the indication that some side effects have occurred, and the patient doesn't want to continue the treatment. So the doctor needs to understand how that has happened and how to go about it. So this is more in a small talk about this adherence, and there are certain more resources which are available online. We can always go and look into it. Thank you. Thank you so much.
Thank you, Professor Munshi. It was really quite exhaustive, and the various ways that are used to encourage adherence to therapy are very interesting to look at. I only wonder whether some of this is possible to do in the Indian setting, where you have so many patients coming in, and you have to quickly the turnover of patients is so high. Nevertheless, I like the idea of having a kind of checklist at the patient's visit, particularly for chronically ill patients, to ensure that they are actually taking the medicine, and check it out all the things that can be done in case it seems that they are not taking the medicine as prescribed. Thank you so much. Are there any questions that anybody would like to address? Dr. Munshi? Well, if there are no other, Professor Munshi, thank you so much for this presentation. We have to go on to the second last presentation of this conference. Is that right? And this is by Dr. Chiranjeev Bagchi. Will he be online? Dr. Bagchi is here. Yeah, here he is. So welcome, Dr. Bagchi, to the desk, and his topic is safe prescribing in hepatic compromised patients. Stage is yours.
So, thank you, sir. I express my sincere thanks to the organizers, especially my teacher, Professor Santanu Kumar Tripathi, and Dr. Shambhu Samazdar, for giving me this opportunity to speak on this issue. In fact, this hepatic, hepatic disorders, in fact, the safe prescribing in hepatic disorders, that's a very important issue. In fact, we know why should I know about this? Because many of the drugs, actually, what we use, most of the more than 50% of the drugs used in the common practice, they are getting metabolized in liver. In fact, either they are metabolized by different enzymes, or the liver transport all these drugs. So naturally, we need to look after this organ function most diligently. In fact, due to this derangement of this liver or this hepatic function, this doesn't already actually intend to have an effect on this desired effect also, but that may lead to the occurrence of some adverse drug reactions. And that's why we need to properly judiciously select the drug as well as to adjust the dosage of the drug. So what are the considerations? In fact, there are different considerations we need to handle these drugs in this particular group of patients, like decreased hepatic clearance of the drugs, as the in fact the hepatic tissue which deal with these drugs and hepatic function that is compromised. In fact, the reduction, there is a reduction of the hepatic blood flow because of these other comorbidities, like the patient if is in shock, or the patient is in critically ill, so naturally heart failure. So there is also decrease in hepatic blood flow. And that has also have an added value. Actually, that parameter is to be considered while treating these patients or adjusting the dosage of this particular drug in this particular group of patients. In fact, decreased plasma protein concentration is a parameter that often happens in case of the patients with the deranged hepatic function. So as you know, the hepatic disease patients, there is decreased production of albumin. So naturally, the free drug level becomes often elevated in the system. And the reduction of the number of the active and functional hepatocytes, decreased first pass metabolism, what is the most important factor which is involved in the drug metabolism, especially in case of the drugs with high extraction ratio. And naturally, when this first pass metabolism gets deranged, so naturally that leads to the increased bioavailability of these drugs. So these concepts and these considerations should also be taken care of while treating the patients, and of course the selection and dose adjustment in this particular group of patients. And impaired renal function, that is also another issue. And we know this hepatorenal syndrome happens in case of the advanced liver disease. And so in addition to take care of this liver issue, you need to consider this renal function, decreasing renal function while adjusting the dosage in this particular group of patients. And we all know that there is a very simple equation to identify or to calculate the clearance of the hepatic clearance of a drug. What is hepatic clearance? That is especially that is the intrinsic hepatic clearance. That means that hepatic metabolizing capacity or hepatic transport capacity of different drugs in this particular patient. And that can be derived with a simple equation, that is by multiplying with the hepatic blood flow, that is QH, with the extraction ratio, that is EH. And this extraction ratio is also, it differs from drug to drug. Some drugs are having high extraction ratio, some drugs are having low extraction ratio. But the problem is that this kind of equations are look very simple, and that is very much good in modeling this drug designing and drug development and phase 1 studies. But it's very difficult to apply in exact clinical practice. Clinically, when a clinician treats a patient, there is hardly any scope to apply this formula to adjust the dosage of this particular group of drugs. And that's why their clinician should consider the other parameters like hemodynamics, alteration of the hemodynamics, and other inherent intrinsic clearance of this particular group of drugs, and the quality of the drugs. That is whether these drugs fall in the group of the high extraction groups or the low extraction groups, and quality of the protein binding in this particular group of drugs. That factor should be considered. And also along with that, the shunting of the blood, that is also an important factor which happens in most of the cases of the advanced liver disease. Intrahepatic shunting of the blood, you all know there is portal circulation is happening there. So that also affects the disposition of the high extraction drugs into the liver, and in fact, the excretion of the bile acids, that is also an important parameter, is recognized as an important parameter for calculation of this hepatic shunting procedure. So that can also be used as a parameter in some occasions, if at all it is to be used, because these the hepatic perfusion and the intrinsic clearance, that is unpredictable in any way. That differs from person to person. So there should not be there is not any clear-cut equation by which you can delve into the exact drug dosing in this particular group of patients like these renal disorders, where we have the cockroach ball formula or MDRD formula and so. So, and in fact, the impairment of the drug metabolism is proportional to the liver dysfunction. So, in a compromised hepatic function, that is where there is a decompensated hepatic failure. In that case, naturally, the drug metabolism is more hampered, more deranged in comparison to this to the patients where there is a compensated state of hepatic function with cirrhosis. So naturally, the way of treatment in this between these two group of patients differ. And now these pharmacokinetic dose adjustments, how it is being done usually by applying several tests that is commonly starting from this liver function test, the Child-Pugh score, the MELD score. Often this MELD score is used before the hepatic transplantation. Child-Pugh score is a very common score, but we all know that all these scores and tests are not very accurate. In some cases, we can apply these scores and these tests. And in fact, in case of the drugs having the high first-pass metabolism, you need to reduce the dose because there is to reduce the oral bioavailability of this particular group of drugs. And because as the first-pass metabolism is hampered in this particular group of drugs. For it is now there is a dictum that is in high clearance drugs, you need to adjust both the loading dose and the maintenance dose. But in case of the low clearance drugs, you need to mention, adjust only the maintenance dose. As the mechanism, as I've explained the mechanism, because in the high clearance drugs, you need to take care of this hepatic intrinsic clearance also. And in fact, in the low clearance, as you only need to adjust the maintenance dose. So therapeutic drug level monitoring is also the monitoring of adverse effects of the is also key that should always be done, because that is one very good tool to adjust the dosage in particularly in case of the low clearance drugs, low extraction ratios. I will come to this point later on. So now this is the Child-Pugh score. It has been published by the US FDA and European Medicines Agency, and that has been integrated into the drug trials and the different phases of drug trials. They apply this score. And this score is actually, this encompasses different parameters, clinical and biochemical parameters, starting from the encephalopathy, ascites, bilirubin, albumin, prothrombin time, INR ratio. And according to that, they have segregated the patients of the hepatic dysfunction into several categories, starting from child class A, child class B, child class C. Child class A is a less severe hepatic liver disease. Child class B, moderately severe liver disease, and child class C is the most severe liver disease. So now what happens in case of the high extraction drugs, as it is mentioned, that is quite accepted, that is these drugs having the high hepatic extraction ratio. So naturally, as these drugs, the oral viability is very less, and this has got a high first-pass metabolism. So what happens in case of if this is deranged, this hepatic function is deranged, naturally there is every chance the oral viability will increase. And so as the first-pass metabolism is affected. So in that case, you need to reduce the dose. How you will need to reduce the dose? You will reduce the dose applying this formula, that is normal dose into bioavailability divided by 100. So in case of this high extraction drug, that is very important is that the hepatic blood flow has got a very important connotation, has a very important impact here in this case of the high extraction ratio drug. And in that case, the clinician need to consider the inherent hepatic blood flow in this particular group of patients. That is the comorbidities, that is the heart failure, that is the shock, that is the other critical illness where the hepatic blood flow is compromised. If the hepatic blood flow is compromised, naturally that will add on to the hepatic dysfunction, and naturally you need to further reduce the dose in addition to this factor applicable for the bioavailability. So these are the examples of different drugs which have this property of high extraction ratio. And the low extraction ratio drugs, more than 70% oral viability, as because the intrinsic clearance impact is less here. So these drugs are having the high, more oral viability. So how can you adjust the dosage here? Here you can apply the Child-Pugh score. So if the patients are having the less severe hepatic disease, you need to adjust the dose in 50% of the normal maintenance dose. In case of the child class B, you need to adjust the dose in the form of 20% of the normal dose. And in case of child class C, you better to avoid this dose, which has got a very, for the drugs which are not at all safe for the hepatic compromised patients. And in fact, you need to consider here also the protein binding capacity, because in case of the low extraction ratio drugs, the protein binding capacity of the drug and the intrinsic ability of the drug, that is intrinsic inherent disease of the hepatic disease of the particular patient, has a great bearing on this particular group of drugs. So that's why, in addition to this dose adjustment, according to the inherent disease of these patients, you need to consider the protein binding here as well. I have mentioned that in case of HED, you need to consider the hepatic blood flow additionally. Here you need to consider the protein binding additionally. So in case of the protein binding, you know this, there are some drugs which has got high protein binding. There are also some drugs which has got low protein binding. So in case of naturally the patient, the drugs having low protein binding, the chance of the free drug level is more. And naturally you need here, the only solution is that you need to measure the free drug level through the TDM. So TDM is very important here in the low extraction drugs. There are some drugs which have got intermediate extraction property, and there is between the 30 to 70% oral bioavailability. And the dictum here is the start low, and for the maintenance, you need to calculate as per the LED drugs. As because these drugs are having the both type of qualities like HED and LED. So here the dictum is like that, and the ciprofloxacin, carvedilol, mirazole, omeprazole, these groups of the drugs fall into these groups. Now it comes to the pharmacodynamics, how it is being altered. I have talked about pharmacokinetics and now pharmacodynamics. There are different responses, altered responses, pharmacodynamic responses here in this case of hepatic compromised patients. One is the increased susceptibility of the patient to hepatotoxic reactions or other adverse effects. And the drugs are implicated in this being is that this acetaminophen, ACE inhibitors, aminoglycosides, they are having increased susceptibility to have some adverse drug reactions or hepatotoxic reactions. Another important factor is that blunted response to the diuretics and vasoconstrictor in this particular group of patients having portal hypertension, because you see that in this case there is the furosemide. The response of furosemide is often blunted. That's why the torsemide is preferred here, because as in ascitic fluid, from the ascitic fluid, actually the sodium excretion rate is it has been studied that is very low in case of these patients with ascites with furosemide. So it's now the furosemide is a very well-recognized drug that is often used in case of the hepatic compromised patients for increased diuresis and these things. And so you need to escalate the dose up to a ceiling effect. And in that case, it is being often stated that the torsemide is better than the furosemide in this regard. And of course, in case of the vasoconstrictors, you need to consider and monitor the patients because there is because of the blunted response of the vasoconstriction. So there might be a reduced response to the vasoconstrictors, particularly in this group of patients. And that's why the physicians need to look after this fact very, very judiciously. Now, the adverse drug reaction in the liver disease, actually liver disease patients, they tackle the adverse drug reactions very poorly. And that's why some group of drugs there is no to use these drugs, like these antitubercular drugs, aminoglycosides, NSAIDs, beta-lactam antibiotics. These group of drugs are often come as a hazardous in this particular group of patients. And the poor nutritional status, renal dysfunction, concomitant drugs, they add values to these deleterious effects. And in fact, some drug-drug interactions should be taken care of. There is alcohol with paracetamol. Alcohol promotes the metabolism of paracetamol and to produce a toxic metabolite. Alcohol increases the gastrointestinal bleeding chance when it is used along with NSAIDs. Alcohol increases the chance of hepatic encephalopathy when benzodiazepines are used along with these. So these types of drug-in-drug interactions should be kept in mind. And next is the antibiotics, because the antibiotics are very frequently used that are needed in case of the hepatic compromised patients. Why? Because the hepatic compromised patients suffer from the lack of immunity, and they are susceptible to infections. And that's why these patients are often need more and more antibiotics. But you see that there are many antibiotics which are to be avoided here in this particular group of patients, like erythromycin, azithromycin, tetracycline, chloramphenicol, bisulfulvins are all contraindicated. And ATD, there is a important, because some of the patients, they need ATD. In case of the, suppose a patient is suffering from tuberculosis as well as the patient is having the hepatic compromised state. And so won't you treat the patient? So there is a dictum, or there is a guideline how to treat this type of patients. So if the cirrhotic patient has got a compensated hepatic function, you can use these 4 drug ATDs. But you should monitor the patients, okay? But the decompensated patients, they poorly tolerate the hepatotoxic drugs. And that's why in case of the child A category of the patients, recommended ATTs can be used, but the patient should be monitored very frequently. And in child case B patients, that is the moderate compromised hepatic function, then one or another hepatotoxic drugs can be withdrawn, like this pyrazinamide should be avoided. Both isoniazid should not be used along with rifampicin, either isoniazid or rifampicin plus ethambutol plus any of the quinolones that should be used for 12 to 18 months. And in case of the child class C, is a severe grade of disease, you should not use at all any hepatotoxic agents. You should use either this combination of this ethambutol plus quinolone plus any second line agent like bedaquiline, maybe delamanid, like this for the 12 to 18 months. So rather regarding the other drugs, that is for the short procedures like endoscopy, then other bronchoscopy, there's procedures. Usually we use midazolam there, but midazolam is contraindicated in decompensated cirrhotic patients. Propofol is a better choice because it is safe and it has a less propensity to induce hepatic encephalopathy. And regarding the anesthetics, isoflurane, desiflurane is preferred, is a safe. Now the NSAIDs are very dangerous in case of the hepatic compromised patients. So this should not be used frequently in this particular group of patients. Acetaminophen can be used in less than 2 grams per day. But if the pain is not well controlled, then tramadol 25 mg every 8 hours is a good choice. But neuropathic pain can be used with treated with nortriptyline, desipramine, or gabapentin, pregabalin. But combination of these drugs with tramadol should not be done. So tramadol, when it is used along, it should be used individually, or the acetaminophen up to the 2 grams per day. But combination drug you should avoid with tramadol, maybe because of the to avoid the hepatic encephalopathy and opioid toxicity. So these are the drugs on the left-hand side should use are frequently used in hepatic compromised patients. You all know that is spironolactone, furosemide, ciprofloxacin for spontaneous bacterial peritonitis, rifampicin and lactulose for preventing hepatic encephalopathy, terlipressin, propranolol, carvedilol to prevent the bleeding from the esophageal varices. And these drugs are absolutely no-no. That is NSAIDs, that is AC inhibitors. AC inhibitors, in fact, they increase the chance of renal toxicity in the case of the hepatic compromised patients and ascitic patients. So the AC inhibitors should be avoided. And even if it is used, there should be dose reduction. So aminoglycosides and gentamicin should be avoided because that will increase the chance of renal failure. To prevent the development of the hepatorenal syndrome, it should be avoided. So the antidiabetics drugs, so in case of the hepatic compromised patients with the with a compensated, that is not in a decompensated state, you can use any of the antidiabetics, but that should be monitored very well. The dose should be adjusted. But in the decompensated patients, naturally the insulin is preferred. Insulin is preferred. Other oral antidiabetics, it should not be used because it will be handled in a different way. So best is the insulin. And the proton pump inhibitors are preferable than H2 blockers because you know these H2 blockers can have the hepatic dysfunction. Statins appear remarkably safe because there are several studies that is we can have this apprehension that statins might be more toxic in the hepatic compromised patients, but statins appeared remarkably safe. There are several studies within hepatic decompensated cirrhotic patients as well as versus the normal hepatic function patients. That is, there is no added derangement or disadvantage with while using these drugs. So sometimes you need to adjust the dosage. These are the several drugs which can cause the acute hepatic toxicity in the form of hepatocellular injuries, cholestatic injury, fulminant hepatitis. That maybe these drugs better to be avoided. Mostly these are the antibiotics, and the hepatorenal syndrome should also be considered. When there is a presence of the concomitant renal dysfunction, you need to adjust the dosage according to the renal dysfunction as well. in the volume of distribution of the hydrophilic drugs that are getting increased in case of the patients with ascites. So the loading dose, it should be increased if you need to have a desired effect in this particular group of patients. And you need to avoid the drugs with narrow therapeutic index. That is to be remembered, particularly in the patients having severe hepatic dysfunction. So the take-home message, the prescribing medicines in hepatic compromised patients is very challenging. As you will know, there is more than 100 drugs can cause the fulminant hepatic failure. And there is actually no clear test which can guide us the drug metabolism and in this particular group of patients. And the most judicious approach is the individualization of the treatment and the monitoring the clinical and biochemical parameters regularly, and the clinical judgment along with backed up with the proper clinical pharmacological knowledge and drug interaction is the key for the successful management of this particular group of patients. So these are my references, and thank you very much.
Thank you, Dr. Bakshi. This is a very complex topic, actually. And thankfully, in general practice, this is, one comes across this less. It is usually severely compromised patients that are there in hospitals where you have to deal with this kind of thing. But very complex, and you presented it very well. So thank you so much.
Thank you, sir.
For that. Are there any questions for Dr. Bakshi? Absolutely. Yeah.
Right. 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 Thank you, sir. Thank you.
Okay. Okay. Yeah. So Dr. Munshi has to leave. Can we arrange for the felicitation?
I request Dr. Shabnawara Begum, ma'am, to please come and felicitate Dr. Shantanu Munshi, sir. Professor Shantanu Munshi, sir. Sorry. Thank you.
So now we come to the last presentation of this conference. The last batsman for the last 6. The topic of the presentation is clinical pharmacology review, reconciliation, and feedback. And this, Shambhu, this terminology you should patent, because it is his terminology, and that is the first time that I ever heard about it. And he continues to persist with this, which is very remarkable. So go ahead and best wishes for the presentation.
So thank you, sir. And actually, this terminology is patented by my mentor, Professor Tripathi, sir. Because when we are preparing some topic on clinical pharmacology reconciliation, so I have a regular habit of sending my PPT to Professor Tripathi before any presentation. Now I am a little bit unfortunate that sir sometimes make my mails mostly in the unread folder. But that day I was fortunate, and sir had edited some portions, and from that I got that terminology. And after getting that terminology, I was just want to publish that also. So we are really fortunate we got some publication on that issue. But thank you, sir, for your comments. So this is the last presentation. Yeah. So So I have a small announcement. As yesterday there was no quiz session, so Dr. Shabnam Ara Begum and Dr. Bhaskar was very keen to conduct the quiz. So in between my presentation, I had prepared some MCQs for you, and I am fortunate that the Dr. Shabnam Ara Begum is here. So as she is also going to most probably host a couple of DM students in near future, because she had opened a clinical pharmacology department, that is course in Archikor Medical College. I don't know how many of you postgraduate students are actually watching us. So you have a provision of doing DM in clinical pharmacology from Archikor also under Madam. So Madam had announced who will give the maximum answer to the MCQ questions. Madam will give some awards. Okay. But again, the disclaimer is that I will ask Dr. Anindo Karmakar not to participate, because you know this presentation. Just 1 week back, we had together present this. So the question is already out to you. So other can participate. So let's start today's discussion. And I think 3 minutes gone. If it is 15 minutes gone, so I think Dr. Shabnam Madam will be very happy, because she had to give less price. So this is a picture I always prefer. I always salute them. And I think many of you are very keen to salute them, these CRPF Jawans. And when we talk about this CPRRF, we also need to be vigilant like these CRPF Jawans, so that there should not be any ball missed by us. So what is CRPF, or rather our CPRRF? This is clinical pharmacological reconciliation, review, and feedback. So these 10 points we had proposed, and this had been very recently published in JCP, Journal of Clinical Pharmacology, that first of all, we need to evaluate whether our prescribed drugs are appropriate or inappropriate, whether we need to do the deprescribing the inappropriate drugs, to identify the omissions or commissions during the transition of care, which is a very critical period, tailoring the dose adjustment to the individual need and perspectives, and preventing, minimizing, managing the adverse drug reaction, improving treatment adherence, as Dr. Munshi had mentioned, affordability and availability, how to improve the adherence on that issue, and individualization of therapy. Along with, we need to tackle the polypharmacy, specifically when we are seeing the geriatric patient, and ultimately enhancing the quality of life. So patient-oriented evidences that matters more, that is POEM, patient-oriented evidence that matters. So POEMs is always preferred over DOEs. What is DOEs? Disease-oriented evidences. So we have to be more patient-specific. So first question to you all, which is the correct option? Select the correct sequence in increasing order for the leading cause of death in US. So option A, cardiovascular disease, cancer, respiratory disease, diabetes. So this is increasing order. So that means in your left side, that is the 4th leading cause. To the right side, that is the first leading cause. Okay, so anyone? How many of, so you had raised your hand. Tell me the answer. C? C first. Anyone? You want to say B? Okay, let's see the answer. What is that? Yes. So Dr. Tanusri got the first prize. Madam, please note. So yes, medical error, they are the third leading cause of death in US after heart disease, cancer, and then the medical error. And you can see this beautiful girl. Very unfortunate incident happened. This is due to a medication error. Something had been done wrongly while giving this intravenous bag of saline. So we lost this girl. We need to prevent this. So when we talk about this CPRRF today, I want to focus on this issue of prescribing cascade. To discuss prescribing cascade, I am selecting two cases. So case one, this is a 68-year-old lady who is suffering from osteoarthritis, hypertension, diabetes, ischemic heart disease. BMI is 36. Last 5 months, she is suffering from pedal swelling. There is both knee joint pain and severe weakness for last 5 days. You can see the current list of medications here, a long list. Along with that, she is consuming fixed dose combination which contains diclofenac occasionally. Sometimes back, 6 months, 7 months back, she was prescribed with this fixed dose combination for her low back pain by some orthopedic doctor for a certain limited period, 5 days like that. But as you know, our patient believe when they are feeling comfortable with some medication, they sometimes make that their habit too. So as she was suffering from knee pain, she was consuming that medication to relieve from the knee pain. And you can see the lab reports here, starting from the HbA1c, which is quite high, with hyponatremia, hypokalemia. EGFR is a little bit deranged. Other tests are okay. Now the second question. What is the most important cause of weakness here? The 4 options are poor glycemic control, chronic kidney disease, drug-induced disorder, and depression. Someone may believe if an option will be like that, all of the above. I think everyone will raise your hand. Yes, it could be all of the above. But my question is, what is the most important cause of weakness here? Then what will be your answer? Yeah. So I think this is the virtue of Professor Tripathi sir's lecture. You now understood that drug-induced disorder is something we need to take care of. So as the patient is suffering from weakness and pedal swelling, now you just think of this pill burden. So the patient is taking furosemide for 7 days. Why? For pedal swelling. And for that, before, if you want to evaluate the pedal swelling thing, you check this medication list and you can understand what could be the reason behind that pedal swelling. Apart from that, if you again go back to that EGFR, that is below 45, and the patient is consuming metformin, a full dose, 2 grams. Patient is consuming diclofenac. So this is critical issues. Now again, another question. The drug group or groups causing pedal swelling, A, B, C, D. Anyone? Which group you were suggesting that could be a right option? Anyone? A? You are telling A? Okay. Who is telling D? Raise your hand. You? So I think there is some confounders. Dr. Anindo is there. Your answer is right. So the patient is consuming pioglitazone, amlodipine, pregabalin, and patient is having pedal swelling. So without addressing that, some physician prescribed furosemide to control that pedal swelling. So this is why we need to suspect drug-induced disorder. Now again, a straightforward question, as we are talking about prescribing cascade, which is the correct option then? A prescribing cascade occurs when A, B, C, D. So patient has an adverse drug reaction and additional drugs are prescribed to control the symptoms of this reaction without prescribing. So that is prescribing cascade. Now, again, you have to tell which statement is false in the context of this case. A, rosuvastatin is independent of EGFR. The dose of rosuvastatin is independent of EGFR, whereas atorvastatin dose is EGFR dependent. How many of you are agreeing with that statement? This statement is true or false? This statement is false. How many of you are agree? Dr. Dipon is there. You too? Okay. How many of you feel that this statement B, glimepiride, pioglitazone, pregabalin, domperidone can contribute in weight gain? This is true. Okay. Now, calcium citrate is better absorbed compared to calcium carbonate in background of chronic PPI usage. True. So this patient, this particular lady, was taking PPI for a long time. Along with that, she was consuming calcium carbonate. She was suffering from osteoarthritis. You know, the calcium carbonate containing medicines are too costly. Tramadol, the patient was also consuming tramadol. Okay. So can tramadol cause hyponatremia? What is the mechanism then? Yeah, so that is syndrome of inappropriate ADH secretion, so CR. So that can cause hyponatremia. So the right answer, as you all mentioned, the first, that is, we should adjust the dose of rosuvastatin according to EGFR value, but atorvastatin dose is not EGFR dependent. This lady was taking rosuvastatin in quite a high dose at EGFR, which is low, that is below 45. So this was done, reconciliation. So in this case, one of the major issue is the body weight. We need to prescribe some medication which can also address the body weight. So we use this GLP-1 analog, dulaglutide, along with we reduce the dose of metformin. Initially few days with basal insulin because hyponatremia was there. Along with, after that, we initiate the dapagliflozin. Paracetamol was started, as also Dr. Bakchi was mentioning the importance of paracetamol. They can be used in hepatic compromised cases too. The calcium citrate salt was used. Atorvastatin 20 milligram with aspirin was given. And also we deprescribed that domperidone, a dangerous drug, D for D. Why? Anyone? Specifically in elderly patient, that can cause some extrapyramidal symptoms. And also domperidone is sometimes prolonged QT. So this is the result. We were very happy with that patient. And sir was asking that whether the physician will be okay with this type of deprescribing practice. So we had published this paper in JAPI, and we are really fortunate that this paper was selected as second best paper in the name of Dr. G.C. Mehta, best case reports by the JAPI, and we got that award too. I think we have less time, and I do not want to bore you with all these things more. I am just going down to case 2, because this is quite interesting. We had faced this case very recently. This is a 67-year-old female, diabetic, hypertensive, CKD, admitted in CCU with CVA, started piperacillin in tazobactam for unknown reason. Initially, today's morning, Dr. Shreyashi Dasgupta had presented a paper where he had shown prophylactically antibiotic was used. Sometimes 2 antibiotics were used. We don't know the reason. Prophylactically, why we need 2 antibiotics. Many cases she had found. So in this case, CVA started with piperacillin tazobactam, 8-hourly. After 5 days of admission, she had chills and high fever, 102 degree Fahrenheit. The total leukocyte count was not that raised. CRP was 35, creatinine 1.6. As already we had mentioned, patient is suffering from chronic kidney disease. Other sensorium is normal. Patient is not that ill looking. And one point is there is no relative tachycardia. So there is clear-cut discordance between the temperature and the heart rate. Blood culture sent, it was report pending. What happened after 5 days of admission, as she was suffering from that fever, she was taking piperacillin tazobactam. The treating physician thinks to increase the dose, increase to the higher range of antibiotic, imipenem cilastatin was initiated 8-hourly. So, day 7 of admission, what happened? There is 3 episodes of generalized tonic-clonic seizure, fever with chill, and that was persisting, no relief from the fever. To control the generalized tonic-clonic seizure, they had used injection lorazepam at 12:30 AM, because that was the time when she was suffering from that GTCS. What happened after giving lorazepam? The patient deteriorated immediately. Saturation is falling down, drowsiness, need of intubation, and mechanical ventilation was given. Now, next day, all those neuroimaging done, echo done, everything normal. Routine blood test, okay. Only the creatinine elevated to 1.9. Obviously, lorazepam was not continued. Levetiracetam was given. Day 9, still fever persisting, and the blood culture sensitivity report came. No growth was found. Now, they had stopped imipenem cilastatin. Suspicion was that this is a case of drug fever. Or just after 4 hours of discontinuation, the patient became febrile. Ultimately discharged after 15 days of admission. So patient was admitted for ischemic CVA, just a lacunar infarct. And for 15 days, she had to stay in hospital. For what? Just for some new symptoms, new disease that occurs due to drugs. And which type of drugs? Unnecessary drugs. unnecessary use of antibiotic. So which statement is not appropriate in this case? Diagnosis written in discharge paper, type 2 diabetes, CKD, CVA. Number 2, carbapenem can cause seizures by their ability to bind GABA receptors and inhibit that GABA response competitively. So whether it is true, if I am telling this instead of carbapenem, I am telling beta-lactams, then is it true or partially true? Then I have to change. It is not competitively inhibited. It is non-competitive inhibition of the GABA receptors. So relative bradycardia and rapid recovery after de-challenging offending agent, these two are important feature of drug fever. Is it true? This is a classical features of drug fever. One is relative bradycardia and number 2 is rapid recovery after de-challenging. And here I want to emphasize on this point, the eGFR value, which considered here inappropriately, specifically when choosing imipenem/cilastatin, leading to overdosing of imipenem. There is no doubt in that when we talk about in critical care setting, the antibiotic dosing, we need to use not to rely on only the eGFR value. We should rather follow the rule of loading dose there. But you can see for 3 days, the patient was taking imipenem/cilastatin in that dose. So if you consider this particular lady, the eGFR was calculated in CKD-EPI formula, and it comes under that 35.1. When we dose imipenem/cilastatin, this is the prescribing information, the label, and you can see it comes between this 60 to 30. So 500 milligram 8 hourly is okay. Then if we calculate like this, so according to the CKD-EPI formula, the dosing is okay, fine, normal. But this is important message. To calculate specifically this antibiotic dose, imipenem/cilastatin, the eGFR calculation should be done by Cockcroft-Gault formula. This is important when the patient's body weight is lower. And in this case, we need to consider that body weight. It is 48 kg. And if you calculate it with this, the same eGFR, it becomes 25.85. So instead of 60 to 30, it should come under that 15 to 30 group. And ultimately, the dosing was inappropriate. And even if in this eGFR, we should continue this 500 milligram twice daily dose. So this caused the prescribing cascade. And what is the prescribing cascade here? First of all, the piperacillin tazobactam was used. And that piperacillin tazobactam, inappropriate use of piperacillin tazobactam caused drug fever. Without understanding that is due to the piperacillin tazobactam, what had been done, they had given imipenem/cilastatin. So now the imipenem/cilastatin use, which was again little bit overdose, that caused a seizure, generalized tonic-clonic seizure. So second adverse event, second drug-induced disorder. And what happened next? The third drug-induced disorder. To control that GTCS, they had given the lorazepam, but unfortunately, lorazepam caused respiratory depression and drowsiness, which leads to mechanical ventilation. So this is a case of prescribing cascade. So that is why we need to reevaluate the absolute need of offending agent using non-pharmacological treatment. Just to do deprescribing, we need to calculate the dose properly and consider alternative drugs. So good prescribing is not a snapshot, it is a continuum, starting with therapy initiation, with dose titration, with changing, adding drugs, switching or ceasing drug therapies. I'm not going in details. There are different concepts. Just finish with these challenges for us clinical pharmacologists. This clinical pharmacology, reconciliation, review, and feedback, this concept can be applied by any discipline. It is not exclusive to us. It can be done by internal medicine specialist, cardiologist, gynecologist, surgeon, if they can do. Our job is, yes, to also increase the awareness about this concept among them also. Even we can improve ourselves if we address these challenges. First of all, the number of specialists providing this service, if we can increase the number of specialists. If we are talking some clinical exposure lack in our postgraduate training, if we can improve that clinical exposure, awareness level and confidence of other clinical colleagues on this concept, obviously the willingness of administrators is extremely important. And last but not the least, clinical pharmacology therapeutics, it is not always possible to become a master of all. Because if we want to become the jack of all trades, we can become the master of none. So it is also important to select different subspecialty domain, maybe one or two, and whether we can become the master of those particular therapeutics area, that we need to think about. Thank you. I think I will not stay standing between you and the prize distribution ceremony. Thank you. Only the last question. This is for me. Dr. Shabna madam told me she will give prize to me if you give the right answer. What, in a 2 word, if you want to describe this picture, what should be that 2 words? Thank you, prescribing cascade. So ultimately, I also will get a 1 prize from madam. Thank you.
Thank you, Shambhu. So we finished with this last presentation, which is actually the core of clinical pharmacology. We all understand that. And it's great that you demonstrated that by case studies. I truly believe that case studies is a wonderful way to understand these things. But for students, I think once you look at that case study, it's just not just looking at that case study and understanding what happened. You have to go back into the mechanisms of how all these, the first drug is causing the first adverse event and how the next drug then gets added, what the clinician's thinking is. That's one. The second thing I think you have to do is, as Shambhu rightly pointed out, we can't be masters of everything. On the one hand, we can concentrate on one specific area, but apart from that one specific area that you might choose, you also need to look at what are the most commonest drugs that are most frequently prescribed. And at least for those drugs and for those conditions, you should have a very clear understanding of how these drugs work, what are the side effects, what are the rare ones, which most people will miss, but as a clinical pharmacologist, it's our duty to be able to spot. So I think, this presentation really helped do that. Any questions for Shambhu here?
Yes, I agree that not trying to be master of all, but at the same time, my clinical colleague would like to look at me that as a specialist, whether I can try to address the problem he is facing. If at all someday they feel confident to refer patients to us. And from that angle, I would say there is a case in trying to be jack of all. And by this, what I mean is I'm trying to draw an analogy with a legal expert. When you visit your legal expert, do you expect that overnight he is going to solve your problem? It takes long time. Many of these kind of problems doesn't require an immediate kind of solution. And nobody is actually expecting. You receive the problem, take your time. Most of these problems will require, maybe if you can give this next day, the solution you give the next day, good, fair enough. And that by that also you can help. Nobody expects you are a moving dictionary, you are a moving Goodman and Gilman. Immediately you give your response. No, not necessary. But you have the wisdom to look at which page of the Goodman Gilman you have to look for, or for that matter, what reference. That might be lacking in your clinical colleague. So you should have the ability to analyze the problem, try to find the right answer from the extensive literature that are available, and get back to your clinical colleague. And for that, you tell him, the trial takes a 24-hour time. Okay, my turnaround time is 24 hours. Even if you go to a microbiologist, he's not giving you the immediately a solution is not given. So take your time, 24 hours, 48 hours. But then during these 24 hours, you have to do your diligence. Okay, and apply your wisdom. The answers are there in the cloud, but you have to pick and choose. Okay, and then contextualize it in the given case situation, case scenario, and then give you all this thing. And use your DM degree that you are vouching for this. And that's what I was also mentioning, that you have to protect your clinical colleague. Medical legally, it also becomes sound. He finds comfortable then. Yes, I have got this advice from a clinical pharmacologist, my learned colleague, clinical pharmacologist. So I would try to look at this way. Thank you.
Absolutely, it's very well said. Thank you, Shantanu. If there are no other no questions or no other points of discussion, is there one, Dr. Bagchi? No, I thought you were putting your hand up. Okay, then we can close this session now. Thank you. I thank the audience for being here till the end of the day and listening to this. And I think you would have missed something if you hadn't. Very useful.
What you have mentioned yesterday in your provision.
Yes.
About clinical pharmacology consulting.
Absolutely.
Now that you are understanding, there is a case for it.
Absolutely.
Whatever has been discussed by and suggested by Professor Tripathi sir, actually I can share my personal experience. I have an experience of working in both in private sector as well as in government sector. And the private sector as a clinical pharmacologist in Apollo Hospital, Kolkata, many years ago. And I was a person who initiated this service, particularly in this critical care setup in this particular hospital many years ago. There's a first time in Eastern India, and Apollo was then first appointing the clinical pharmacologist. It is a story of 2006. After passing my MD, I was doing this service. In fact, I can share this to the youngsters that it was the very first day when I joined into this post. Actually, I seek help from Sir. Sir was acting as MSVP then in RPGMER, and Professor Abhijit Hazira. These two doyens helped me a lot in implementing this service there at Apollo Hospital. Nobody knew by that time because the administrator didn't know about it, the physicians didn't know about it, how they can utilize a clinical pharmacologist there. The very first day I can remember the pharmacy head. Actually, they were then working in consultation with the Apollo Chennai. The Apollo Chennai and Apollo Hyderabad by then appointed as clinical pharmacologists. Apollo Indraprastha still they didn't appoint. And then he said, please you visit our critical care consultant. He is the first person, right person who can guide you how to implement this service there. And he is a person, he is still working there. He is the chief of critical care in Apollo. He is a South Indian, Dr. Suresh Ramasubban. He is a US trained. He is US board certified critical care consultant. He knows how to utilize the clinical pharmacologist in this critical care setting. And the very first day when I met him, I found the right person. So he then first, he spent only half an hour with me and he said that how these things happen in US. And he described everything to me that what is expected from you. And mind it, one experience I had from IPGMER hospital, I did my MD from IPGMER. One very good course curriculum was there. By then, we had to spend in the clinical departments for consecutive 6 months at a stretch. without going visiting our parent department. Only we needed to visit our parent department in case of seminars and journal close presentation. And we had to take the clearance from the clinical department before joining our pharmacology department. And that was under Calcutta University, that curriculum was there. But that was abolished under this West Bengal Health University. Now, the NMC is vouching for the same. And I have learned a lot of this clinical care during my attachment in the cardiology department. In this cardiology department, they used to apply this Cocktail formula, this MDRD formula, this hepatic drug calculation in the critical care unit. And I have learned this in regular ward round, and I have been in practice in doing the same every day clinical round there. So that experience helped me a lot in implementing this service there in Apollo Hospital. And within 6 months, I have developed that service. We did regular critical care round. There are 7 critical care units. Nowadays, it has been increased to 12. And in consultation with the clinical care consultant, he advised me to utilize Sanford guideline for antibiotic policy. It's still available. I do have this. I carry this one for our setup also. And I have utilized BMJ. It is not BMJ, BNF. BNF for this day-to-day drug dose adjustment. Dr. Abhijit Hajra has given me that BNF copy. He is a keen follower of BNF. He carries all the BNF additions with him till date. And he has given me that copy. And I used to carry that BNF along in my apron. And I used to make round there. I had to adjust the doses, drug doses, including every critically ill patients. I gave feedback to them, and they referred the cases to me. So this was my experience. So how this way you can implement this service in the critical care setup that is mostly sought after area in the, for the clinical pharmacology application. So this is my humble, and now we are applying the same in the tropical medicine as well. Here one great initiative has been taken care of by the ID specialist. Every week we are having a multidisciplinary case discussion meeting on every Wednesday in School of Tropical Medicine. They have started DM Clinical Pharmacology ID course also. They have excellent teacher, excellent young stars coming from EMS with DM ID qualification. We have very good interaction there. We have pathology department, we have a very good microbiology department, we have clinical pharmacology department, and they refer the cases to us. We regularly receive the referral from the ID departments for this drug, for soliciting these drug related problems. And I am personally taking charge of this standard treatment guideline, convener of the standard treatment guideline formulating committee, and we have completed the same. It is going to be published recently. So we are planning to do hospital antibiotic stewardship there, and it's a big issue there, and we are hopefully will be able to do it in the coming month. So we are now in this way, we are approaching or we are applying our concept into this clinical care, and our administrator also helping in this regard very well. Thank you very much. I wanted to share this with the youngsters. So hope for the best. Thank you.
Thanks for sharing that really. Closing comments?
Felicitation then. So I would like to invite Professor Shantanu Kumar Tripathi sir, and to felicitate him, I would request Dr. Shogal Mukherjee sir to please come up onto the stage. So you are felicitating? Sir. Yes.
I've learned after
I would also request Dr. Shogal Mukherjee sir to please stay back for the felicitation of Dr. Chiranjeev Bagchi sir. Felicitations, sir. Sir, one more felicitation, the final felicitation of Dr. Shambhu Sambhat, sir. Probably, sir, he is the best person to answer that question. Okay. So Dr. Shubhadeep Sinha, sir, has commented, what a picture, two of the living legends of clinical pharmacology in one frame. Hopefully in the next conference, we will be having more such clinical pharmacologists in a single frame, all the stalwarts together.
No, Professor Shantanu Tripathi and Dr. Shoaib both have been mentors to countless pharmacologists and clinical pharmacologists. So if you can call, like some have been Arjuns and some have been Ekalavyas, but they have been Dronacharyas for all of us.
Indeed, sir.
Up to this point, you are showing interest. So you have gone back and still you are looking at conference proceedings. That's great.
I wonder, sir, whether you have been able to hear what sir had just commented. Sir has
Something, yes. Yeah, that I have not slept off. I have not slept off during the conference. I have not gone elsewhere. I have been listening throughout. Because very rarely does a pharmacologist get invited to a clinical pharmacology conference.
Thank you so much, sir, for your participation. Next, we will move on to the valedictory session. So I would like to invite Professor C. Prabhakar Reddy, sir, to please come onto the stage to announce the prizes.
Yeah, Dr. Sinha sir is there. You can go and announce it. Sir, you can go and announce.
Hello, Dr. Sinha sir. Can you hear us, Dr. Sinha sir? Hello. Hello, Dr. Sinha sir, can you hear us?
Yeah, I'm there.
Yeah.
Please. Ready, go to the mic.
No, both I and sir have. So I want just sir to say a few words.
No, it was quite an interactive session, although I kind of interfered in the in between too many times. But the best part is that all the students, they have, all the participants, they have done those studies in a very resource constrained settings. And despite at least they should get a applause for the, if not, even if they have not got the prize, for the effort that they are putting in for doing these studies, whatever they can do under the settings, and they really deserve that. This shows the intent and their talent. And despite hardly any support, they can do this. When they have a lot of support, I think they can do much more. That is one point. And secondly, I think Prabhakar, Sab, you announced that part. I think what we had discussed regarding our award.
So it is better to announce. I think we can ask all the.
No, Dr. Shubhadeep Sinha requesting you to announce the next part. What you have discussed, both of you.
That award related.
Award related, okay.
Awards, only awards. I think we can ask all the competitors to stand up.
Please stand.
So one thing here we have decided is, as I was speaking with Shambhu, we are planning to give a second prize for oral instead of poster presentation.
Okay.
So with the permission of him, we have given a second prize.
There were 4 posters,
But,
we were not, according to will tell. Okay.
So we just wanted to, so last time what happened, it happened the same way, but we didn't give for posters. So this time we want to convert that to this one also.
So does that mean that you are?
No.
Giving 2 prizes to oral?
Oral.
But no prize to the poster?
Poster. So this will not repeat, sir.
But that is to some scientific. Okay.
Okay. So this will not repeat. This is a one time because we want to encourage them.
Okay, I am.
So this is what we have done. This is a one time process where when we get next more things, we will do it that way. Sir. So first we have seen whether it is having any clinical relevance to society. If you are going to put it, your study into society, is it going to be useful or not? So next time what we'll do is we'll frame a criteria for selecting. And the first thing, remember, it should be ethics committee approved. Okay. That will be the first point. Ethics committee approval. Without that, you should not, you should not even send it for acceptance for your this thing. Just please see that. It's not only for you, even for your guides, because it might be a violation. Okay. So here, first prize goes to any expectations from viewers? Yes, somebody is holding back hands like this.
I think that we can announce the second prize.
Okay. Second prize, any expectations? So this was very good study. Except himself. But we have to satisfy our, we have to keep our organizing secretary happy. So we listen to our organizing secretary. So the second prize goes to one study that was done on FDC. Yes. I'm not, what is the number? 4, I think. Yes, Dr. Palomi Ghosh. Congratulations. So we expect you to do the full study, present it in your department, present it to your hospital whole institute, where they'll come to know what are the FDCs that were not being prescribed as per regulatory. Okay. So we want you to take it forward and see that this, see that we are becoming more useful to the society. Okay. Congratulations. Any words, sir? This is a second prize.
So first and second doesn't matter. All are winners, and that subject is very topical and it is very important in today's pharma industry. That India is flooded with fixed dose combinations, and there is a lot of struggle for the last 10 years to weed out mostly irrational FDCs. The intent is very solid, and please keep it up and do much more studies on this subject. India needs more such efforts. Thank you.
Thank you. So no. Oh, that's bad. Sir is there. We like direct everything to sir.
Shantanu sir.
Have to bless us, including sir. Okay, we are small people in age, and so we should not do that. Okay. This first one, any expectations? I gave a hint. I gave a small hint while I said somebody folding their hands like this. So, Dr. Shravan, might be the results are not what we want, but this is going to play a major role in future, where genetic polymorphisms may go for personalized. So we want you, and remember, in Olympics there is a saying, it's not who wins, it's whether you participated or not. That is more important. Okay, so best of luck and see that you do more of these things. Okay. Congratulations.
Congratulations.
So one small photo for all participants. First, second, and sir in background.
Yes.
No, yeah, Shantanu sir and Shoibal sir should also come.
You want us to participate and compete? No.
No. I mean to say the real gurus should be there.
Sir, we will do that one. We also will participate, but hetero should sponsor the first prize.
No, we can't say that now.
Hetero to sponsor the first prize.
No, we can't say that now, sir. Now the NMC guidelines.
No, we'll say Dr. Sinha sir is sponsoring.
Oh, okay, I'm sponsoring. Fine.
So the first prize in Dr. Naidu's name, second prize in Shobha Madam's name. Who's going to give now?
All the content is all the content is. All the content is now. That is becoming prominent. Come from me, then keep on the. Come on, people. Keep on. Ready. Ready. You come this way. Ready. One more. Thank you. সামনে বসতে হবে দেখা যাবে না চলে এসে রোহন চলে এসে আমি আর রোহন সামনে বলছি আর একটু লম্বা দীপন চলে এসো আপনি এদিকটা চলে আসুন ম্যাডাম আপনি এদিকে একজন এদিকে চলে আসুন আপনি সামনেটা আপনাকে দেখা যাবে
Ready? Ready? Ek minute. Bye.
So I would request Professor Shantanu Kumar Tripathi, sir, to please come onto the stage for the concluding remarks, sir. Just one formality left.
No, I would say that it was a wonderful experience. For the last 3 days, we are really quite busy. And the few people who are still here, and maybe a few more people online, would appreciate certainly that it was, the conference was academically quite sound and rich. The participation or the number of people physically present might be low. There might be a few more people online, but otherwise, subjects, topics that have been discussed, they were very relevant. There were also very lively interactions. And as we leave today, at the end of these 2 or rather 3 busy days, we go with more clarity on the role of ourselves and the role of, or the place of clinical pharmacology in the overall perspective of patient care as well as regulatory science. Hopefully, the society will find its more rightful place in the therapeutic environment, treatment environment, as well as access to affordable care in the country in years to come. Thank you very much. Thanks, everybody. Special thanks to the organizers, led by Dr. Shambhu Samrat Samazdar. A big hands to Shambhu and his team. Thank you. I must thank Dr. Shreyashi Mukherjee to have this patience and care shown to us. It's a great encouragement. And thank you again, as I have always been your admirer since the first day I met you. Thank you. Yes, of course.
Fantastic. Wonderful.
And we'll be not doing our duty if we do not mention particularly about this institute. They have given a huge support. Thank you. Thank you, Medica, for your support. So all of us will join in national anthem and all of you please come with them. The naam to likh. So Dr. Bharti, you have to with mic. Again, it will not be. Please come, everybody can join. Yes.
जनगण मन जाब सिंधु गुजरात मराठा द्राविड़ उत्कल बंग विंध्य हिमाचल जमुना गंगा उच्छल जलधि तरंग तब शुभ नामे जागे तब शुभ आशीष मागे गाहे तब जय गाथा जनगण मंगल है भारत भाग्य विधाता जय है जय है जय 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 जय